ഐഡിയ ഇല്ല.
Hello, ma'am.
Hello.
Oh, I'm audible, ma'am.
Just a minute.
Yeah.
Hello. Start either. Oh, okay, sir. Okay. Carry വരുന്നേ ഉള്ളൂ. അതെ. Okay. Okay, sir. Good evening, ma'am. Anyway, I think we can wait for 5 minutes for everybody to join.
Okay.
Hello. ഞാനൊരു കാര്യം ചെയ്യാം. ഞാൻ ഇതിലോട്ട്
Hello.
Hello. Hello. Good morning. Good evening, sir. Audible?
Yeah. Good evening. Good evening. Good evening.
Good evening, sir.
Good evening, madam.
Good evening, sir.
Tangu. Dr. Tangu.
സാറേ
നമുക്ക് ആക്ച്വലി സ്റ്റാർട്ട് ചെയ്യാം. അവര് ജോയിൻ ചെയ്യുമ്പോ അവരെ ഇത് ചെയ്യാം.
അതെ അതെ സ്റ്റാർട്ട് ചെയ്യാം.
കാരണം വെച്ചാൽ 6:55 ഓൾറെഡി 6:55 ആയില്ലേ?
അതെ അതെ നമ്മുടെ സുചിത്ര മാം ജോയിൻ ചെയ്യാമെന്ന് പറഞ്ഞിരുന്നു. സുഭാഷ് മല്യ സാർ ഒരു 5 minutes എടുക്കുമെന്ന് പറഞ്ഞായിരുന്നു.
അല്ലല്ലാതെ സുഭാഷ ഉണ്ടല്ലോ. സുഭാഷ കാണാലോ.
കാണാമോ? എനിക്ക് ഫാക്കൽറ്റി എന്നാണ് എല്ലാം എഴുതി വന്നിരിക്കുന്നത്, അതുകൊണ്ടാണ്.
അല്ല, സുഭാഷ് അവിടെ ഉണ്ട്.
എന്നാ പിന്നെ സ്റ്റാർട്ട് ചെയ്താലോ സാറേ?
സ്റ്റാർട്ട് ചെയ്യായിരിക്കും ബെറ്റർ.
So, good evening, dear Sujitra ma'am, Subhash sir, our immediate past president and KFOG coordinator Kunjumuddin sir, our chief guest Dr. Durga Das, our guest of honor Dr. Pradnya Supte, dear seniors and all my dear friends. I welcome you all to the 7th episode of the second series of the KFOG webinar series. And as we all know, under the able leadership of Sujitra ma'am, our Secretary General sir, Subhash Malya sir, Kunjumuddin sir, and and with the help of all the seniors, this academic series has kept the flame of knowledge lit in the heart of every KFOGian. And as we all know, imparting knowledge to a medical personnel is equivalent to teaching or treating 1,000 patients. So today, together with Dr. Rani Lakshmi, chairperson of the Fetal Medicine KFOG, we are conducting a webinar with active participation from all the 5 societies of the North Zone, that is Calicut, Kasargod, Perinthalmanna, Cannanore, and Wayanad. We have a galaxy of eminent speakers from all these 5 societies. So I welcome you all to this academic feast. So now, may I welcome Dr. Kunjumuddin sir, to introduce the chief guest and the guest of honor.
Did they join? Dr. Tangu, did they join?
Sir, അവർ join ചെയ്തതായിട്ട് കണ്ടില്ലല്ലോ.
That's what I'm telling. We will take them up
when they join, we will.
Okay, sir.
Subhash, അവര് വരുമോ?
ഒരാള് ഫ്ലൈറ്റിലാ സാറേ, മറ്റേ ജോയിൻ ചെയ്യാന്ന് പറഞ്ഞിട്ടുണ്ട് സാറേ.
So when they join, we'll give them the slot to speak.
ഓക്കെ. അപ്പൊ അങ്ങനെയാണെങ്കിൽ സാറും സുഭാഷ് സാറും ജസ്റ്റ് ഒരു 2 വാക്ക് ഇതിന്റെ ഒരു
സുചിത്ര മാഡം ഇല്ല?
സുചിത്ര മാഡം 5 മിനിറ്റ് എടുക്കുമെന്ന് പറഞ്ഞു.
Okay. Subhash, say something so that we can kick start. Subhash.
Madam, good evening, madam. Good evening, madam. Respected Suchitra madam, Kunyumidin sir, and all the senior members of the fraternity, all the chairpersons of the respective committees, and all the professors from all the colleges and the senior consultants here. The topic for today, madam has chosen a very nice topic of panel on autoimmune diseases also, and critical care. And the crux of this is, we will have a very nice discussion about almost about 1 hour. But I believe it is not just going to be superficial talk. It's going to be, in-depth analysis of all the things that we would like to learn from this. So I would like to congratulate Dr. Rani Lakshmi and Dr. Tangu Thomas for all the pain and efforts that they have taken in making it a reality. And I also like to thank Dr. Kunyumajit sir for all the support which is given in initiating this EDGE series and taking it forward. Kunyumajit sir, thank you very much for your efforts. And I would like to share the mic with Dr. Kunyumajit sir to please give a couple of words, please.
Yeah, thank you, Subhash. And dear faculty, delegates, at the outset, I congratulate the participating committee, the Medical Disorders in Obstetrics Committee and the Fetal Medicine Committee, the new vibrant committees of KFOG, along with the participating societies having organized this wonderful webinar and academic program on critical things in obstetrics and fetal medicine. So I hope it will be a big academic event today with a lot of discussions and take-home messages, and wish the team all the success for a wonderful program today. Thank you.
Thank you, sir. So may I invite Dr. Subhash Malya sir, our Secretary General, to say a few words.
No,
He already told.
he already spoke.
ഓക്കെ സാറേ, നമ്മുടെ ചീഫ് ഗസ്റ്റ് ഓഫ് ഓണർ ജോയിൻ ചെയ്ത കണ്ടായിരുന്നോ? എല്ലാം ഫാക്കൽറ്റി എന്നാണ് വരുന്നത്.
സുചിത്ര മാഡം ജോയിൻ
അതാണ് ഞാൻ എല്ലാവരും റിക്വസ്റ്റ് ചെയ്ത് ഞാൻ മെസ്സേജ് go to the name and then change your names. Please go to your names and then rename ചെയ്തോളൂ, സ്വന്തം പേര് rename ചെയ്തോളൂ.
Because it's very difficult for me. Everything is coming as faculty.
Ma'am has joined. Dr. Suchitra has joined. You can invite her, I think.
Now may I invite Dr. Suchitra ma'am to deliver the presidential address.
Good evening to all. Can you hear me?
Yes, ma'am.
Sorry for the delay. There's some confusion about this. I was not getting the background. So first of all, I would like to congratulate our chairperson, Tangu Thomas, for Dr. Tangu Thomas for taking so much of effort, because this is a mega webinar. I think this is one of the biggest webinars that has been created in the recent time, right from medical disorders. That is a very unusual medical disorder, that is autoimmune diseases, and also fetal medicine. And there are nearly 5 societies, right from south to north. And also so many topics are there, which are going to be discussed. So, and we have we have national faculty, Dr. Durga Prasad. And also, I would like to mention our immediate past president, Dr. Kunyumidin, whose brainchild is the KFOG EDGE webinars. And this has kept all the district chairpersons, all the chairpersons on their toes. And everybody is aware and doing something very active. So, thank you so much, sir. And also to our Subhash Malya, our Secretary General, who has just landed back from Japan. I was scared he will just get stuck in Japan, but now he has come back. We are so happy to have him back. And once again, I wish all the chairpersons, all the experts, all the faculties, the national faculties, everyone, all the best. And I'm sure this is going to be a wonderful seminar, because it covers a big broadband, a big rainbow of topics, actually. So wishing all success. Thank you so much. I sign off.
Thank you, ma'am, for the kind words. So let me pass on the mic to Dr. Rani Lakshmi for introducing the first speaker in the fetal medicine session. Dr. Rani Lakshmi.
Yeah. Good evening, all. Tangu kekamo?
Kekam.
Okay.
Audible.
So the first session is our fetal medicine topics. The chairpersons are Dr. Suma Vishnu and myself. Dr. Suma is a consultant OBG and a fetal medicine specialist from Wayanad, from Vinayaga Hospital, Sultan Batheri, and she's also the founder treasurer of Wayanad OBG Society. Myself, associate professor in Kottayam Medical College and chairperson of the Fetal Medicine Committee, Kerala. I invite Dr. Suma to introduce our speaker. We all know he's a wonderful speaker. We are all happy to hear from him, Dr. Sineesh. Suma, please introduce Dr. Sineesh.
And sorry, madam. Dr. Rani Lakshmi is also the secretary of Kottayam OBG Society.
Okay. I forgot. Suma?
Thank you. Yes, madam. Thank you, Dr. Rani, and thank you, Dr. Tangu madam, for giving me this wonderful opportunity, and thank you, Sujitra madam, Subhash sir, and Kunjumuddin sir for this excellent webinar series. So let me come to my job. My job is to invite the speaker for today, Dr. Sineesh sir, and I think he needs no introduction at all. He's a very famous personality or person in the field of fetal medicine and a very beautiful orator. He's currently working as the chief consultant in fetal medicine and fetal therapy in Aegis Mother and Child Hospital, Perinthalmanna and Astam Hems Kottakkal, Kerala. And he did his MBBS from GMC Alappuzha and his fetal maternal medicine from Simar Edapal, and he has many post PG degrees from all over India and outside India, and he has almost 30 publications in national and international peer journals. Now he's currently the prominent secretary, Society of Fetal Medicine, Kerala chapter. So over to you, sir, and we are eagerly waiting to hear from you.
Thank you so much for the wonderful introduction. I assume that I'm audible, first of all.
Yes.
Yes. So
Yes,
thank you
sir.
thank you so much. Thank you the entire KFOG team, Kunjumuddin sir, Suchitra madam, Rani madam, and the all all the delegates who have taken time out to listen few core topics in maternal fetal medicine. So today I'll be speaking on fetal growth restriction. Actually, this 20 minutes or 30 minutes is not enough for this. So much updates and so much new information is coming on fetal growth restriction. What I have done is to select few cases from what we have seen in our clinical practice. And before we go into those series, some new concepts are having updated, terminologies, definitions, etc. have been updated. And then we will actually go through the cases. So some of the basic concepts in fetal growth restriction. Now we all know this, that assessing fetal growth is an essential part of the prenatal care. Because fetal growth restriction, small for gestation fetuses, they account for about 1/3 of all pregnancies in the third world countries. Suboptimal fetal growth, in fact, accounts for 30% of stillbirth. A wonderful study done by Gardosi et al. Way back in 2005 showed that of all the late stillbirths, 30% were undiagnosed late onset fetal growth restriction. And we now know this fetal growth restriction is an entity not just confined to the fetus, to the neonate or the infant. In fact, it has got long-term implications on the health of that adult, especially cardiovascular, profile. And this we call as the adult onset disease of fetal origin because of deranged fetal programming. Now, let us get some of these terms right. What is growth potential? Now, every fetus, when a pregnant mother comes to an antenatal OP, every fetus has a capability of growing. That inherent capability for growth endowed on that fetus is called as a growth potential. And the growth potential is determined by ethnicity, by the parental, that is both the fathers and mothers, anthropometry, the parity, and fetal gender. When this growth potential, when the fetus fails to achieve the endo's growth potential, we call that condition as fetal growth restriction. In fact, this is the most accepted definition for fetal growth restriction. Now, people often confuse fetal size from fetal growth. Now, for example, a pregnant mother is coming to me for fetal biometry. I take the fetal biometry, I take the estimated fetal weight. Now, this is called as fetal size. That is, when we take fetal measurements at a particular point of time, this is called as the fetal size. But what is more important for us is the fetal growth or growth velocity or the interval growth, which is actually the incremental growth over a period of time. So these are some of the basic terminologies with regards to normal and abnormal fetal growth. Now, we also know that compared to antenatal examination, ultrasound is the standard for fetal growth assessment. We take estimated fetal weight as an indicator of how well the fetus is growing, and we use Doppler in high-risk pregnancies. These are actually the tools to assess the fetal size when an antenatal mother comes to the ultrasound OP. We take the estimated fetal weight, and right now, of all the 70 plus formulas that we have available for calculating estimated fetal weight, we use Hadlock 3 formula because multiple studies have shown that this is the most superior formula in correlating the normal fetal growth. So this incorporates the head circumference, the abdominal circumference, and femur length, and we calculate the EFW. Note how the biparietal diameter is not used. Once we take the EFW, we have to see whether this is normal or abnormal. So long back, we used gestation age as an indicator of whether the fetus is growing well or not, right? So for example, the gestation age is 32 weeks and the AC is like 31 weeks. We used to say like the fetal AC is lagging by 1 week, but this is now obsolete. This is also substandard. Now we use centiles. We use centiles to depict whether the fetus is growing well or not. And how to get the centiles, we have the growth charts. And added to the growth information graphs, we show how the fetus is growing over a period of time. So this is the concept of fetal size, the interpretation of fetal size, whether it is normal or not, and then plotting the fetal size over a period of time in charts to get the growth velocity. So this is a typical third trimester growth scan, which is done at 36 weeks. We can see that the gestation age is 36 weeks. 1 day, the EDD has already been assigned. And we see that this is actually the fetal biometry here, the BPD, HC, AC, FL, etc. And the estimated fetal weight has been calculated using the Hadlock 3 formula, which is shown here, the Hadlock 3 formula. And we see that the fetal weight is 2.1 kg, which is at 3.1 centile. And what is not shown here is the growth chart. So in this particular growth report, we have used the WHO growth standard. As per the latest evidence or recommendations from ISUOG, the International Society of Ultrasound in Obstetrics and Gynecology, growth standards have to be used to obtain centiles from fetal biometry. And here we have used WHO growth chart, which is an example for a growth standard, and the centile is 3.1. And then on the other side, we have the information from the multi-vessel Doppler. We have the information from uterine artery. We note that the mean uterine artery PI is reduced. The umbilical artery PI is more than 95th centile, and the MCA is less than 5, and so is CPR less than 5. So this is a typical report for a late onset FGR, late onset fetal growth restriction, where the growth has fallen beyond 32 weeks. So delivery part, the management part, we will see later. This is the concept of growth chart. So growth chart is basically a depiction of fetal growth over a period of time. So for example, this particular woman had an anomaly scan around 21 weeks, and then she straight away landed at 36 weeks. So we can see how the anthropometric measurements such as BPD, HC, ACFL are varying over the period of time. Noteworthy here is to note how the estimated fetal weight has fallen over the period of time. And for example, the abdominal circumference from near to the 50th centile, it has now come around 5th centile. So growth charts depict how the fetus is growing over a period of time. Fetal size is basically biometry and EFW at a particular point, and interpretation of the fetal size is done with centiles. Now, long back, we had some traditional risk factors to assess a pregnancy, whether this pregnancy is prone to develop fetal growth restriction. We know that none of these risk factors are very useful, and they particularly perform very poor. That is, they're very suboptimal for the prediction of late onset FGR. But now we have this new biochemical and biophysical parameters to identify pregnancies that are high risk for development of fetal growth restriction. Noteworthy here is a PAPE, which is less than 0.4. We know that PAPE is a part of the biochemical test. Now, sometimes we get positive and intermediate screening biochemical test reports, and all that we think about is trisomy 21. But remember, any positive, any intermediate screening test which has a normal karyotype identifies a pregnancy which is prone to develop fetal growth restriction. Similarly, uterine artery in first trimester with a pulsatility index of more than 95th centile, not mean, it is the mean PI, not the right and left, identifies a subset of pregnancies which are prone to develop fetal growth restriction. And these are some of the advanced ultrasound findings during anomaly scan, which helps us in identifying pregnancies which are prone to develop fetal growth restriction. Now, since the last 10 years, we now know that we don't have a symmetrical and asymmetrical fetal growth restriction. This is a highly outdated concept. Now we have what the so-called phenotypes of fetal smallness. We have the early onset, late onset fetal growth restriction, and then we have SGAs. Now, basically, SGA means the most accurate definition is the estimated fetal weight of such babies is between the 3rd and 10th centile. The Doppler findings are completely normal. The amniotic fluid volume is normal. And when we follow up these pregnancies over a period of time, remember what I told the growth chart, the interval growth is normal and the perinatal outcome is normal. So these are a set of babies which are having estimated fetal weight on the lower side, but otherwise grow well. Early onset FGR, late onset FGR, they are basically two different subtypes of fetal growth restriction. Now, their primary difference lies in the type of placental disease in them. So whereas early onset FGR is due to severe uteroplacental diffusion, uteroplacental insufficiency causing perfusion defects, the late onset FGR is due to mild uteroplacental insufficiency, where there is a problem with the diffusion of the nutrients. So by definition, early onset FGR develops prior to 32 weeks, whereas late onset FGR develops after 32 weeks. And we can also see that there is very high association of preeclampsia with early onset and very less with the late onset fetal growth restriction. The management of fetal growth restriction is very simple. As of today, there is no drug, there is no intervention for the management of fetal growth restriction. We have to balance two things. One, prematurity and acidosis. So if we deliver too early, complications of prematurity. If we deliver too late, acidosis leading to cerebral palsy and death. In fact, the sole management of FGR is surveillance and optimizing time of delivery with the key object of intact survival and good future neurodevelopment. Now, whenever a small baby is encountered in antenatal practice, I encourage every obstetrician to ask these 5 questions. Only these 5 questions, because every answer will be there in the 5 questions. Is the fetus actually small? If the fetus is actually small, what is the phenotype? What are the chances for intact survival? When to see her next, and when and how to deliver? So basically, the diagnosis of FGR, phenotype of FGR, initial decision making, surveillance, and delivery. So is the fetus actually small? We know that we have to verify the dates. And for verifying the date, we use a CRL, which is the most ideal measurement for dating. Now, if some of the youngsters in the audience doesn't know, this is the guideline that now we follow for for dating of pregnancy from ACOG, American College of Obstetrics and Gynecologists, a consensus statement that has come in the year 2017. And these are the criteria and about how we have to date the pregnancy. Sometimes some of us in the periphery do get a case with no first trimester and they directly land up in second trimester. Then we have to date with the head circumference. But even if the growth is normal, we have to call for interval growth. Third trimester, if the woman lands up in third trimester, no organized reports of first and third trimester. Again, we date using the HC, but here we can use additional parameters such as long bone epiphysis and the transcerebellar diameter. Now, having verified that the dates are correct, and the fetus is actually small, this is how we classify the fetal growth restriction. One, we have the small for gestation age fetuses. We already saw estimated fetal weight between 3 and 10, and Doppler findings are normal. Fetal growth restriction, here there are signs of uteroplacental insufficiency, and the growth is usually less than third. Very important distinction in FGR is whether this is due to placental cause or non-placental cause. Now, non-placental causes includes your chromosomes, infections, they have bad prognosis from the beginning. Placental FGR, we classify them as early onset FGR and late onset FGR. Now, the most updated guideline for definition of fetal growth restriction is the so-called Delphi consensus, where a group of people who are experts of fetal growth restriction sit together and they have come up with the guidelines on how to define FGR. So according to the Delphi consensus, early FGR is defined as one which develops prior to 32 weeks, no congenital anomalies, and any one of this criteria, that is AC less than third centile, EFW less than third centile, absent or reversed end diastolic flow, or AC or EFW less than 10 centile with one of these findings, that is a resistant umbilical and uterine artery Doppler. So late onset fetal growth restriction, according to Delphi consensus, one which develops after 32 weeks, there are no congenital anomalies. Either straight away the AC or EFW is less than third centile, or the ACFW is less than 10 centile with crossing centiles, means fall of more than 50 units with an resistant umbilical artery or a CPR less than fifth centile. Now I will share the Delphi consensus with Soma. She can share in the group. Now, the third important question after identifying the fetal growth restriction case and also determining the subtype is whether this fetus will survive or not. For example, a 20-weeker estimated fetal weight first centile and absent or reverse industrial flow. We know that this fetus is not going to survive and we can offer terminational pregnancy. Similarly, FGR with presence of anomalies, chromosomal and genetic abnormalities, and typically FGR with polyhydramnios or normal Doppler is a red flag. So we should be able to identify cases of FGR which have poor outcome, and if they're within 24 weeks, we can offer them termination of pregnancy. If they're beyond 24 weeks, we can reduce the surveillance and do conservative management and maximum non-interventions. The fourth question is when to see next, and the Barcelona guideline is best for that. And they have divided all the FGR cases into 4 groups based on the Doppler findings. So the stage 1 is with mild placental insufficiency, where one of these criteria are there, and we can see these cases every week. But stage 2 is when there is an umbilical artery absent industrial flow. These cases we have to see them 2 times in a week. Stage 3, when the umbilical artery is showing reverse industrial flow or DVPR is more than 95th centile, we have to see them every 1 or 2 days if delivery is not planned immediately. And stage 4, where there's a reversal of A wave and DV and so-called reduced short-term variation CCTG, we have to see them twice a day, again, if the delivery is not planned immediately. Similarly, stage 1, we can wait till 37 weeks and we can go for induction of labor. Whereas for stages 3 to 4, they have to be delivered at particular gestational limits as defined by the Doppler. For example, stage 2, we can deliver by 34 weeks. Stage 3, where we have reversed industrial flow, by 30 weeks. And when there is a stage 4, that is really abnormal DV, by 26 weeks. And stage 2, 3, and 4, preferably by cesarean birth. Late onset FGR can be delivered at around 37 weeks, but all depends upon whether the CPR or MCA is abnormal. So if the CPR and MCA are normal, we can wait till about 38 weeks. But if CPR and MCA are abnormal, and depending upon the individual discretion, these cases can be even delivered earlier, such say, for example, close to 36 weeks. SGA, there is no doubt they can have term delivery if everything is normal, that is between 38 to 40 weeks, and we can offer induction of labor in such cases. During the surveillance, if any of these factors are present, such as DVA wave reversal, reverse industrial flow in ductus venosus, or when there is a pathological CTG or maternal deterioration, we can modify the surveillance and advise for delivery. Very important point here is that while performing surveillance for the fetus, we should not forget the mother also. So let us look at. Sorry, there is a disturbance from the background.
Requesting everyone
So I'm going to some practical scenarios very quickly. This is a case 1, a typical late onset FGR. Look at this case. When she came at during the anomaly scan, everything is normal. At 20 weeks, the estimated fetal weight was 55 centile. Nothing wrong at this point. No preeclampsia, nothing. But then she lands up at 36 weeks, and the estimated fetal weight is now 3.1 centile. And as per the Hadlock 3 formula using WHO growth chart. And we can see that all the Dopplers are abnormal here. The uterine artery is abnormal, the umbilical artery is abnormal, and the middle cerebral artery PI and CPR are less than fifth centile, which shows that there is a high possibility this fetus is hypoxic. Now, an important message here is when the CPR or when the MCA PI are less than fifth centile, it is almost sure that the fetus is hypoxic. All right. So this is a typical late onset fetal growth restriction, and we can see that the growth charts show a fall in all the biometric parameters. So here, since she is 36 weeks, she falls into stage 1. So late onset FGR, as well as the cases of mild early onset FGR, are all put together under stage 1, and we can deliver them by 37 weeks. Now, remember, within this late onset FGR, we have two groups. One where the MCA and CPR are normal. In those cases, we can wait till 38 weeks. But those cases where the MCA and CPR are abnormal, we can think of delivering them little early because of the risk of stillbirth in them. So there is a little bit gray zone in late onset FGR, whether to deliver around 36 to 38 weeks. Two guidelines have come about this, and they're very, very complicated. To make them very simple, if CPR is less than 5th centile, if there is an abnormal NST, if there are maternal indications, poor perception of fetal movement, deliver close to 36 weeks. If the CPR and MCA is more than 5th centile, in a case of late onset FGR, then we can deliver them around 38 weeks. So late onset FGR, we can deliver them between 36 to 38 weeks, taking multiple things into consideration. So this study from the Garda survey shows that late onset FGR is the most important cause for third trimester stillbirth. Now, this case, I want to point out, this is a 31-weeker, which came at, which came for a routine scan. And look at here, the centiles are normal, 70 centile. But then there is a small red flag here. The uterine artery is resistant. So if you just look at the, estimated fetal weight, we would dismiss this case and probably do not perform another scan and straight away deliver, ending up in a stillbirth. Let's see what happened to this case when she came at in the next visit. Now, when she came at 35 weeks, now the estimated fetal weight has fallen to 22 centile. And at this stage, we can also note that the fetus is hypoxic. The fetus is hypoxic. Note how I want to point this very thing, that the umbilical artery is normal in this case. So because the fetus was hypoxic, because there was a fall of growth centiles, and because the CTG was not looking great, the patient was delivered close to 36 weeks. The baby did well, albeit some neonatal complications such as polycythemia. So this is a subtype of late onset FGR where there is a fall of more than 50 centiles, or which are also called as 2 quartiles. And often this is missed because in the first visit, the centile will be normal and we don't bother to do another scan, or maybe we don't look clearly at this case. Again, the centile. So in this case, the centile had fallen from 70 to 22. That is fall of more than 52 units. This is what we mean by a fall of 2 quartiles in late onset FGR. So again, another case, the third case that I want to show here, the estimated fetal weight was 8th centile here, but look at how the abdominal circumference is at 70th centile, whereas most of the other BPD, HC, etc. are low. The AC is 70th centile, and the estimated fetal weight is coming around 8th centile. And the umbilical artery, the uterine artery are all normal, but the middle cerebral artery is abnormal. This is again a very typical scenario for stillbirth. This happens when there is a combination of gestational diabetes mellitus with a late onset FGR. Because there is a gestational diabetes mellitus, the fetal AC is on the higher side. Luckily, in this case, the overall AFW was still less than 10, but most often we see that the estimated fetal weight in such cases would be somewhere between 10 and 20 centile, and they can be missed. And in this case, the MCA was the only thing abnormal. So this fetus is hypoxic and they have to be delivered as soon as possible. So I'm skipping these two cases because they are very typical, early onset FGR where typical surveillance was done. And one important point I want to mention here is the use of steroids in FGR. Now, ideally, a course of steroids should be offered just before delivery. We should avoid multiple doses straight away at 31 weeks, umbilical artery resistant, other things normal. Don't offer steroids at this point. Offer steroids when we are planning delivery as per the advice from the fetal medicine specialist, because the repeated dosages of steroids have been associated with suboptimal neonatal and childhood developments, especially cranial biometries, and suboptimal performance in academics. Many researchers are coming in this field, and a simple message here is, as far as possible, offer a single course of steroids just prior to delivery. You can take the advice of the fetal medicine specialist in that case. Also, another problem with offering steroids is that there will be a temporary improvement in Doppler due to a corticotropin releasing hormone mediated pathway, which causes vasodilatation. And we feel that the Dopplers have improved. So I think, Suma, you might have also seen this in some of your cases where we offer steroids and suddenly the Dopplers become normal. So this is again a recipe for disaster. All right. So a combination of all these modalities should be used. Now, CTG, biophysical profile, A5 have all now become, as individual parameters, they are not useful. We should use a combination of this along with multivessel Doppler in doing surveillance and decision making in fetal growth restriction. Now, these 5 to 7 cases are FGR with normal Leica, normal Doppler. Just wanted to point out that always we should think about genetics, a little bit of genetics in such cases. So this is one case which we had, straight away landed in 3rd trimester, reduced fetal growth, and the baby had a microdeletion syndrome affecting the chromosome number 13. The baby had poor growth after delivery. So there are certain cases of FGR where we need to do genetic testing, and always we should take the advice of fetal medicine specialist and geneticists in such cases. So this is another case where the baby had FGR along with cleft of lip and palate, and this case turned out to be a Cornelia de-Lange syndrome when postnatal testing was done. So I think the important take-home messages are: ask these 5 questions whenever you see a small baby. Is the fetus actually small? What is the phenotype of smallness? Is there a chance this fetus is going to survive? When to see her next, and when to her, and how to deliver? Delphic consensus, the most updated, most superior criteria for definition of placental FGR, both early as well as late onset FGR. The Barcelona Protocol, published in 2014, is the best guideline to decide, to advise us regarding how to perform the monitoring and how to decide upon delivery. They do also mention how to diagnose FGR. So with this, I conclude my presentation. Thank you for the patient listening.
Thank you, Dr. Sinish, for that exhaustive presentation. I hope all agree that it was really very useful, not only for the residents and also for the upcoming obstetricians. And I think the important point was missed low MCA and CPR in late onset FGR, which is often very missed. The umbilical artery Doppler would be normal, and the MCA and the CPR will be going less than the 5th centile, and I think that should not be missed. And one important point he said was that the importance of looking at the uterine artery Doppler and the 2 quartile fall in the estimated fetal weight. I think those are the very important points that he should think of, we should think about. Any queries? Tangu, queries എന്തെങ്കിലും ഉണ്ടോ?
നോക്കട്ടെ, ചാറ്റ് ബോക്സിൽ അങ്ങനെയില്ല, കാണുന്നില്ല.
Okay.
Any
Suma, you want to add on anything, Suma?
Nothing, madam. Actually, sir did a great job on IUGR, and I think fetal growth restriction, it is one of the commonest case we encounter in our day-to-day practice. And really, once a patient walks into your OPD with a fetal growth restriction, it's a great dilemma for us to counsel the patient when to terminate the pregnancy and whether there will be prematurity. And I think that if we feel there is an abnormal Doppler, then we have to have a multidisciplinary team, a counseling with the fetal medicine specialist and with the neonatologist or pediatrician on board, and make them the importance of regular follow. That's very important, because they have to come weekly at Doppler assessment. They have to have that they should know the importance of the regular follow. That should be well counseled before delivering the baby, because prematurity is very common in these cases. So sir highlighted all the points very nicely, and the case scenarios are really very gave us very practical points. Thank you so much.
Sinish, I want to ask something.
Yes, ma'am.
We have from periphery, we have lots of reference for early onset FGR with the TORCH screening. Should it be a routine, or what is your point about that?
So what I feel is, when we have this early onset FGR around, especially around 20-24 weeks, it is always nice to test for everything. So our protocol is that we, do the genetic testing for the baby, because you saw some cases where there was surprise diagnosis of some genetic abnormalities. When coming to fetal infections, 2 important points I want to tell here is that most of the women in India and in Kerala, they are already seropositive for CMV and toxoplasma. They are already seropositive for CMV and toxoplasma, but both these infections have the potential for a reinfection. So if we do a TORCH, we should be able to do further testing as well. So for example, if the toxoplasma or CMV IgG is positive, we should also do an avidity along with the test to see whether this is a recent infection. And in certain cases, we can do an amniotic fluid RT-PCR for CMV and toxoplasma. That is 100% diagnosis for fetal infection. And another important point is from my practical case scenarios is that rarely these infections present just with FGR. They will have some other problems as well. They will have some CNS findings. They will have some hyperechoic bowel. So for example, recently a woman came to me for her third pregnancy, and I went back to see her second report. In the second pregnancy at 33 weeks, there was FGR with ventriculomegaly. And when this baby was born, the baby had all the manifestations of cytomegalovirus. So chorioretinitis and other manifestations were there. So yes, there are some other additional clues when you have FGR with this infection. So it is better to refer to a fetal medicine specialist to do a detailed anatomical survey, look for these additional findings, CNS, extra CNS, and to consider whether we have to test the fetus or not.
Thank you, Sinish. Sinish, one more scenario. Only if the MCAPI is less than 5th centile after 32 weeks. Is there a case like that? We have to follow as same as CPR as the 5th centile?
So that is a very good question. And because there was not much time, I didn't put that here. So if the fetal growth is normal, that means the interval growth is normal. There are no falling centiles. Everything is normal. Then it is normal to have MCA and CPR, especially MCA less than 5th centile after 35 weeks, because there is a physiological increase in the diastolic flow in MCA. However, I want to point out that there have been some publications which have come in last year, which shows that even in the AGA, that is appropriate for gestation age fetuses, abnormal MCA Doppler were associated with adverse perinatal outcomes and neurodevelopment scores. So we don't have a large information on how to manage these cases. More and more studies are on the way. So if the fetus is growing well, interval growth is normal, NST surveillance is fine. After 34, 35 weeks, we can ignore the MCPI, which is less than 5th centile. But at the same time, we can perform a continuous NST surveillance during the intrapartum period and take care of these babies after birth also.
Thank you. Thank you. Tangu, it's noted that the chat is disabled. People cannot ask questions, I think. Chat disabled on the message. Can
I also share a case?
Sure.
Sinish, we
Yes,
had,
ma'am. Please.
3 days back, we had a second gravida. First was a previous cesarean section. This pregnancy, it was totally uneventful. First trimester NT scan was normal. The second trimester 20-week scan was normal. And 33 weeks also the scan was normal. But then the percentiles were not given. And we were planning a section because she was 37 weeks, right? Yeah. We were planning a section next week. But because of all this listening to you guys, I was unsure whether to go for a repeat ultrasound, because anyway I'm going to do a section for her. She already has a scan at 33 weeks which shows that everything is abnormal. Then I told my PGs, see, we'll do an ultrasound. This is just to know whether I have to do a CS today. Whether I find some abnormality and I have to do the CS today itself, or I can wait for 4 or 5 days. And you know what? The ultrasound came as absent and diastolic Doppler with a pathologic CPR. We don't get the usual percentile things. So otherwise the patient was absolutely normal. Just because if you go for a single ultrasound, we're likely to miss that late onset FGR. And then we did an ultrasound, the baby, we did an emergency section and the baby was 2.3 kg. But okay.
Right.
Doing well now. So that importance of having that 2 ultrasounds at 32 to 34 and repeating at 36 to 37 weeks is also important.
So the solution to this problem is in low resource scenarios where the patient cannot afford repeated scan, the best time to do a third trimester ultrasound scan is 36 weeks. At 36 weeks, we would be able to pick up all these late onset FGRs, some of the mild early onset FGRs, the placental issues such as morbid adherence, late onset anomalies, etc. But where resources are okay, like for example in private hospitals where patients can pay, we can have 2 ultrasounds The first one ideally done between 28 to 30 weeks, and the second one can be done between 35 to 37 weeks. So if we do a two-stage growth scan, as Madam told, we would be able to pick up most of this late onset FGRs. Otherwise, if the patients are not affording, then instead of this 32 and 33 weeks, it is this is actually a meta-analysis data which shows that the best time to do a third trimester ultrasound scan is 36 weeks. But I think at least for most of the patients, we can offer them a low-cost two growth scan at 30 and 36 weeks. That would be able to pick up most of the problems.
Sir, there are some queries in the chat box. What if the MCA Doppler abnormal at about 32 to 34 weeks and later becoming normal at about 36 weeks?
So when so it is a duty of the ultrasound specialist to repeat an abnormal Doppler finding every time. That is, whenever we get an abnormal finding, repeat it after some time to know whether it is normal or abnormal. Second thing we just now discussed, if the fetus is growing well, the interval growth is okay, the surveillance parameters are okay, probably we can put this patient under increased surveillance, but have term delivery with a continuous intrapartum monitoring.
For centile fall by 50%, duration between two scans.
They should be at least about 4 weeks, but usually practical scenarios, they happen over a period of about more than 5 to 6 weeks or more.
Then a gestational age of 30 weeks, 2 days with 2 weeks disparity in AC, uterine artery Doppler more than 95th centile with normal other Dopplers. When to see her next?
So again, if we come back to the initial slides, the gestational age difference is not enough. We need to know the centiles, right? We need to know the centile of the EFW. So if the EFW centile is low and as uterine artery is resistant, this is a case of early onset FGR. So umbilical artery, MCA, Doppler, if they are normal, we can see them after a week, probably after a week. Even after 2 weeks is also okay, but safer side to see them after a week. But the scan should be complete. We should know the centiles of the estimated fetal weight.
Should we do genetics testing for all cases of sudden IUD in IUGR cases?
So when an IUDs happened, our options are limited for genetic testing. The best thing that we can do is take a fetal specimen from the thigh, heel, and do a chromosomal microarray because karyotype has a high culture failure rate in this scenario. So we can do a microarray. But ideally, whenever we have an FGR and if a fetal medicine evaluation has been done, it is better to do a prenatal testing. Postnatally, the ideal test would be an autopsy or an infection testing if possible, and a microarray from a fetal specimen, from a neonatal specimen.
Is it easy to do, or is it necessary to do uterine artery Doppler in third trimester?
Uterine artery Doppler should be done in all the trimesters, first, second, third. It is maximum efficacious, that is maximum sensitivity seen in first trimester. And as we go into the second and third trimester, the sensitivity to pick up abnormal events go down. But as a protocol, it would be nice to do uterine artery Doppler in all the trimesters. That keeps your learning curve intact.
Effect of aspirin if uterine artery PS is high. PA is high.
You meant to say that uterine artery PI is high and we started aspirin, right?
Yeah.
So aspirin can ideally prevent
Definitely,
only
we
those.
have to.
Yeah, uterine artery PI is increased. We can start aspirin low dose. Ideal would be to do a biochemical test for preeclampsia as well. But if the resources are not available, we can definitely start cases of abnormal placentation where the woman is going to develop preeclampsia and the fetus is prone to develop FGR. But as such, aspirin has no effect in preventing occurrence of FGR alone.
Dose of aspirin.
No doubt about that. I think this should no more be a question now. It's 150 milligram for a woman weighing more than 45 kg, less than 40 kg. Such women are not seen anywhere. But if the woman is weighing less than 40 kg, then 100 milligram.
Okay. Okay, thanks for the delegates. That's a wonderful interactive session too. Lots of questions to Sinish. Thank you, Sinish, once more. Tangu, I think we
Thank
can
you.
move on to the next session then.
Thank you, Ran Lakshmi and team. So next we'll be having a very rare topic as for the panel, that is autoimmune diseases in pregnancy, balancing the flares and the fetus. So the moderator is none other than Dr. Mumtaz. Dr. Mumtaz is a professor who is working at the MES College, Medical College, Perinthalmanna. And she has bagged almost all the premier gold medals in KFOG and has bagged gold medals in AICOG only also. So over to you, Mumtaz.
Tangu, thank you.
For your
I am not
beautiful
able
panel.
to share the screen.
Okay, no problem. Is it possible?
Sir,
No.
stop sharing.
Let me give it a try.
Still no. Sanish has to
Stop sharing.
I mean, stop screen share. Is someone already sharing the screen? Sanish is or Suma? Sanish is.
Sir.
Dr. Sinish?
Sanish has to stop.
Please,
Hello?
Dr. Sinish?
Yes, I am there.
Okay.
Sir, can you please stop the screen sharing of your PPT?
Yes, I will.
Thank you, sir. Thank you, sir.
Is it okay? Are you able to share?
No, it's
No, not yet. It's still now.
Is it from the admin side? Because
So you have to stop, I think, Sanish.
okay, I will
share.
stop it. Yes. Okay, I'm done.
Yeah.
Now it looks okay.
Yeah, fine.
Sorry for that.
So, good evening, respected seniors and dear friends. At the outset, I think I shouldn't be thanking enough Dr. Tangu for all the effort she has been putting into this. Every other day, there will be one question in the group, whether everyone is reading, everyone is practicing and all that. She is like really behind us on this. Thank you so much, Tangu. Yeah. So today we have discussed the panel. We have a discussion on. Can you see the slide? Is my slide visible?
Yes.
Yes.
So the topic is autoimmune diseases in pregnancy. And today we have with us Dr. Ramya from Cannanore, Dr. Kunisa from Kottakkal MIMS, Dr. Sabnam from Cannanore, and Dr. Suma from Wayanad, Dr. Vinod from Kasargod, Dr. Vinny from Calicut. And we are fortunate to have two experts, Chalama Madam from Calicut and Dr. Shashirega Ma'am from Cannanore. So without wasting much time, because it's a large topic, the first question is it really there, this autoimmune diseases? So data say that there has been an increase of about 20% in last 30 years. So definitely the number of pregnancies presenting with disease is also increasing. How does one get it? It has got a genetic or environmental predisposition. Now, why women and why pregnancy? Women unfortunately or fortunately undergo various hormonal changes throughout her life. And this transition, these endocrine transitions also make them more susceptible to autoimmune diseases. And many of these diseases present or manifest for the first time during pregnancy because this is influenced by the T cell cytokine mediated responses and hormonal, immunological, and body changes. So now we are going to talk about enemy within. So these diseases are characterized by tissue damage, which is inflicted by self-reactivity against one's own tissues through mechanisms of immune system, that is antibodies and T cells. Because of the lack of time, we have restricted to the, though there's a long list of, I think somebody else is talking side by side. If that can be muted, it will be better. Okay. So there are a long list of diseases. Now, I think for today's discussion, we'll restrict ourselves to systemic lupus erythematosus, antiphospholipid syndrome, and immune thrombocytopenia. So this, if a patient has one of these, that pregnancy becomes a high-risk pregnancy. She is more prone for first trimester abortions, preeclampsia, eclampsia, FGR, PRO, and preterm birth. And these antibodies can cause a placenta and can have an impact on the fetal heart also. And these diseases are characterized by remission, sometimes exacerbations. So the basic principle no.
So please, everybody, please mute.
I think, Tanku, you will be able to mute others.
Let me see. Continue, Mumtaz.
Also, then I can unmute myself.
Okay.
So planning pregnancy at the time of remission is very important. And even then, we need to have a close follow-up in managing these pregnancies. So first coming to systemic lupus erythematosus. Now, Dr. Ramya is going to tell us about what are the features, basic features of this disease, that is SLE.
Madam, I'm audible?
Yes, you're audible.
So SLE is basically an autoimmune disease. So you have autoantibodies directed against the nuclear antigens, and this forms immune complexes. And these immune complexes deposit in the various organs of the body, causing damage. Why is it important? Means typically a young woman of reproductive age group was prominently affected with this illness. And you typically get a young woman with a mala rash, little bit of oral ulcers, coming to us with arthralgia, arthritis. That will be the main presentation. And maybe you may have some signs of organ dysfunction, maybe some thrombocytopenia, maybe a bad obstetric history, thrombosis, maybe a cardiac involvement or a renal involvement. Majority of the patients, when you screen, when you get a clinical feature like that, you will do ANA testing. More than 97% of the people.
We'll come to that later. Yeah. We'll come to investigations later. Okay, then. Yeah. So, Dr. Ahmad Nisa, what do you understand by this flare in pregnancy, or what can you like to tell us about flare in pregnancy?
Madam, can you hear me?
Yes, please.
Yes, madam. Flare in pregnancy, that means the active disease in pregnancy. That is, a patient who is in remission can have an active disease in pregnancy. That is flare in pregnancy. And flare in pregnancy, the incidence is around 25 to 60%. The risk factors for flare are those who are having an active disease 6 months prior to conception and in primary gravidas, and those who are having a history of lupus nephritis prior to conception, and those who have an history of discontinuation of their routine medication like hydroxychloroquine and low C4 component prior to conception. These patients are at risk for flare in pregnancy.
Dr. Sabnam, please enlighten us about the maternal complications. Dr. Sabnam? Dr. Sabnam hasn't joined. Okay. So maybe some net issues. So maternal mortality is higher in these women. It was found that in SLE, the mortality can be as high as even 20-fold higher. And one of the maternal complications that can occur is preeclampsia. Compared to the general population, the rate is about 4.6%, but in SLE, it can be as high as 30%, the incidence of preeclampsia. Dr. Suma?
Yes, madam. Yes, madam.
Any other maternal complications that we?
Yes, yes, madam. As we already told, the incidence of preeclampsia is very high in those with autoimmune diseases. And so basically the vascular pathology is there. So preeclampsia itself can cause iatrogenic prematurity. And preterm birth is the most common obstetric complications in patients with this autoimmune diseases. And in normal population, when the rates is around 5 to 6%, but in patients with autoimmune diseases, it's as high as 15 to 50%. And that causes a huge morbidity in the newborn. Because of the vascular pathology, fetal growth restriction is also very common in those with SLE, and also low birth weight is also very common. So because of the fetal growth restriction, even again iatrogenic prematurity can occur in those with SLE. So the incidence of FGR is almost 30%, as high as 30%. So we have to monitor for FGR, Doppler abnormalities, preeclampsia in all the mothers who are affected with SLE.
Dr. Vinod, are you there? Dr. Vinod?
Yes, ma'am. Yes, ma'am. I am there.
Yeah. So now, Mas told us about the antenatal complications. What about the neonatal problems?
In SLE, we usually see the neonatal lupus. This is basically because the maternal autoantibodies like anti-Ro and anti-La antibodies crossing the placenta. These antibodies go and attack on the fetal myocardial tissue. Usually, the other complication includes the cutaneous and hematological and hepatic issues will be there. And the antibodies attacking the myometrium causes the AV dissociation in otherwise normal structured art in the fetus. This will lead to the serious complication like complete art block. And the cutaneous lesions are usually self-healing one, like within the 6 months of the baby birth.
The mother may or may not have the diagnosis of SLE also sometimes.
Yeah.
Sometimes that is also possible. So the most serious complication is congenital heart block. Vinod has already talked about it. And when there's a history of previous congenital heart disease, congenital heart block or cutaneous lesions, the risk is...
Yeah, the chances of the subsequent birth with complete heart block increases with the previous history.
Dr. Vinny, now we know this, this can affect the mother with preeclampsia, prematurity, abortions, FGR, and all that, and can affect the neonate also. Now, how can we go ahead with planning the pregnancy? Dr. Vinny?
Yeah, ma'am. So basically, as we all know, this is a high pregnancy. So once a diagnosis of SLE in a mother has been made, what we have to do is, if we get the patient preconceptionally, that is the best time to do a baseline evaluation. Very important is to take the history of the last 6 months. So whether there was any history of an active flare of the disease, like an acute arthritis or some cutaneous lesions. So any past history of a flare in the 6 months is very important for the maternal as well as the fetal prognosis. Also, we have to go into previous obstetric history, like Madam said previously, though SLE is usually seen in primary gravidas and in the younger age group, the prognosis worsens as the age increases. So if the previous pregnancy had any complications of pregnancy loss or a fetal growth restricted baby, or there was a history of preeclampsia, especially early onset preeclampsia, and there is a suspicion of SLE, definitely we have to go about the investigations. Also, we have to see the basic investigation, whether they were done, especially if it is done in the preconceptional period, a complete blood count along with the renal.
We'll come to that investigations later.
Yeah,
so it's important that she's not in the active phase, and even for the last 6 months, she shouldn't ideally have a disease process, right?
Yes, and if she has any history of a renal involvement, that has to be considered very seriously. Any drugs which were there have also been
right?
Yes. The contraindications for patients with SLE to get pregnant is definitely a history of severe pulmonary hypertension, lupus nephritis, and also severe restrictive lung disease. Also high dose of corticosteroids, because as we all know, that is a very high risk for the mother and the baby to have complications. And what they say is that in the last 6 months, if she had a history of an active disease, the possibility of an obstetric or a neonatal complication is as high as 60%. So keeping that in mind, a well-controlled disease is much better to go into a pregnancy.
Okay, thank you. Dr. Ramya, so we plan pregnancy by looking at the SLE complications and comorbid conditions, and also we have to look for certain other complications also.
Yes, madam. Basically, you have to stratify patients whether they're it's a mild SLA or it's a moderate or a severe form. If it's very mild and there are other comorbid conditions like thyroid and diabetes, you have to clear that. If it's a mild disease, very mild rash and all things, you can go ahead with pregnancy. If it's a moderate disease with in a very minimal flares, the patient can at least wait for 6 months before she plans pregnancy, because you need to see what drugs she has to continue. You can change the drugs, maybe start folic acid and such drugs depending on what medication she is taking. So at least for 6 months you can give contraception, and already complete contraindications for pregnancy has already been told.
Yes,
so if it's a mild case, she can go ahead. Yes, ma'am.
So before she becomes pregnant, would you like to do some investigations, Dr. Amar? So we have to have the basic investigation of CBC and renal and liver function test and ESRL. Yes. Dr. Sapnam has joined or not? Any idea? Dr. Sapnam? Still not there. Okay. So all this DNA antibodies, a complement, anti-ROSS antibodies, all these antibodies can predispose to neonatal lupus also. So when we have facility to test all this, ideally we should test all this, including the complement, antiphospholipid antibody, lupus anticoagulant, anticardiolipin antibody, because these things coexist. So after checking all that, that means when we have a patient with SLE, we have to have a set of investigations and see that there is no disease in the past 6 months or nephritis. And if the answer is yes, it is a contraindication to become pregnant then. If the answer is no, then we look at the comorbid conditions, whether it is present or uncontrolled. Then again, she cannot become pregnant then. If there are no other comorbid conditions or complications, look at the medications. Some medications are contraindicated in pregnancy. So when they are not safe, postpone pregnancy or switch over the medicine to safer drugs. And these safer drugs, the best is to continue hydroxychloroquine, and strict follow-up is required. So that is a basic thing. So at the end of evaluation, we have a patient who is fit to become pregnant, and she conceives and comes back to us. So we have to have the pre-pregnant medication management. Dr. Suma.
Yes, madam. So the most important part is the drugs which she is already on. So mostly these patients with SLE will be on hydroxychloroquine, and sometimes if there is any acute situations, they can be on steroids or analgesics. Mostly they be on all these 3 drugs. So hydroxychloroquine, it is actually safe in pregnancy, and most of the studies shows that continuing hydroxychloroquine throughout pregnancy can reduce the rate of flares in pregnancy. So we can safely give hydroxychloroquine and ask them to continue in pregnancy. And regarding the use of analgesics or steroids, analgesics actually we have to restrict the use of analgesics for fear of closure of PDA in late trimesters, and also in early trimesters. If they are on chronic analgesics use, there can be a chance of oligomneos too. So the use of analgesics should be done with caution, and the use of hydroxychloroquine should be encouraged in cases with SLE.
So actually, it's a long list of drugs which can be used, selective use in pregnancy, all immunosuppressants like glucocorticoid, azathioprine, sulfasalazine, cyclosporin. but there is also some drugs which are contraindicated in pregnancy. These women can be on these drugs like methotrexate and cyclophosphamide prior to conception. So ideally, they should be switched to alternate therapy 3 months prior or 6 months prior before attempting pregnancy. Dr. Vinod,
Yes, ma'am.
what things are there important things in managing her pregnancy?
Ma'am, as it's told, like its management starts from before the conception, and during the pregnancy, we should have regularly monitor the disease activity in the patient, and we should often see the clinical examination, laboratory examinations, laboratory evaluations should be done to the patient, and patient should be asked to regularly visit the doctor every fortnight in case of like in SLE, and at least once rheumatologist consultation should be done in every trimester to the patient, and as and when required, the frequency can be increased depending on the disease activity. And in clinical examination, the patient should be monitored closely for the development of any flare, which may development of any proteinuria, development of any hypertension. We should assess the patient.
Coming to laboratory tests, sometimes we have the pregnancy also has an effect on these tests. So there can be some cytopenias, thrombocytopenia can be there in pregnancy.
Yeah, in hematological, like in CBC, we usually find the pancytopenia, like pictures in SLE, like leukopenia and thrombocytopenia. But when it compared to with the hypertension, with the preeclampsia like condition, when we compare to that, it is more of neutrophilia in the preeclampsia compared to the SLE.
Dr. Binny, for further management of during pregnancy. I think this is already told here, isn't it?
Yes.
Reena,
Just that, madam, the urine and creatinine protein ratio should be monitored carefully. And also,
is breaking, Binny. The voice is breaking.
Okay. Can you hear me, ma'am?
Oh, yeah, now it's fine.
Yeah, so basically, the urine protein and the urine protein creatinine ratio has to be monitored carefully, and also look for urine protein casts, because that will help us differentiate between a simple, a preeclampsia with proteinuria and casts which are present in autoimmune disease.
Right. So, again, liver function test, because sometimes in intrahepatic cholestasis, acute fatty liver help also.
Yes, so usually in SLE, liver function will not be as deranged as in a HELP, or in hypertension when there is an acute flare, or in active, acute cholestasis of pregnancy, the liver function will be more deranged than an SLE. So that is a factor which can help us differentiate.
ESR and CRP, Dr. Ramya.
Madam, ESR is basically always elevated in pregnancy. It's a natural thing. So we cannot use ESR to see if the patient has got a flare. And CRP, the problem is even infection can increase CRP. So that is out of focus. So mainly we use double stranded DNA levels to see if it's a flare or not. That will be a good test. Other than that, complement naturally in pregnancy, it's going to increase. And if you feel that complement levels have gone down with the suspected flare, you can take it as a flare. So only dsDNA and the falling trends of complement will give you an idea about the disease flare. Yes.
Now further into the fetal well-being, Dr. Suma. Is there any
Mumtaz Beena here from Cannanore. Shabnam is there actually. She is not able to unmute herself.
Oh, Dr. Tangu.
Am I audible now? I actually logged out and logged in again now. Am I audible now?
Yes, you are audible. And
okay.
Yes.
Okay. Dr. Suma, what about SLE pregnancies? Is it any different when we think about the
Yes.
ultrasound pregnancy?
Regarding the maternal fetal monitoring. Yes, madam. Because early onset IUGR also we have to rule out in cases of ladies with SLE. because during the NT scan itself, we can do a uterine artery Dopplers and see whether it is high in a high resistant flow or whether there is a high pulsatility index for the uterine artery index and PI. And if there is a increased resistance, then definitely at 18 weeks, we have to get a ultrasound done to rule out early onset FGR and also to rule out anomalies too, because they can be on some teratogenic drugs, as we already told. So that also can be ruled out. And if she is on an active disease or an active flare, it's ideal to get a growth scan done every 4 weeks, because we have to monitor the growth, because the chances of late onset FGR, the chances of Doppler abnormality, the chances of developing preeclampsia and the growth restriction due to preeclampsia is very high every 4 weeks, which we doesn't usually do in a routine ANC. And if the and according to the follow-up of the FGR, if the Doppler is abnormal or if she is going for late onset FGR, then we have to call accordingly weekly ultrasounds if the Doppler is abnormal, and then terminate a decision and take a decision on termination of pregnancy as according to that.
Dr. Ahmed, other than ultrasound, how do we look into these fetuses?
We can do non-stress test and that can start 4 to 6 weeks prior to the date, and especially in patients with anti-Rho, anti-La antibodies, we have to take a fetal echo, and better to have a pediatric cardiology consultation, because there is a risk of complete congenital heart block that is in 2% of the patients. So we have to look for the fetal heart rate. If the fetal heart rate is less than 60, if the heart rate is less than 60, definitely should be seen by a pediatric cardiologist.
Dr. Sadnam, everybody is talking about preeclampsia, IUGR caused by preeclampsia and all that. So something
Yes,
about
ma'am. Yes, so preeclampsia actually, as mentioned earlier, the rate is very high compared to our normal, the normal population. So as a prevention, as we all do, we have to start aspirin, and low dose aspirin is given to women, especially with SLE, because they have a high risk of developing IUGR. So we have to give, as already mentioned in the previous seminar, 150 milligram. The range is mentioned as between 80 to 160, but with the normally, as previously mentioned by Dr. Sanish, it is 150 we have to give as a preemptive measure to reduce the incidence of preeclampsia as well as the sequelae, that is IUGR. And when do we give it? We have to give it between 12 to 36 weeks. Sometimes we may give it higher, give it for a longer period of time, especially those women who have a sequelae of APLA, like stroke and MI. And even if they do not have APS, we have to give aspirin to prevent the preeclampsia as well as IUGR.
Dr. Vinod, so SLE also affects the kidneys. Preeclampsia also affects the kidneys. How can we differentiate between preeclampsia and an SLE flare?
Ma'am, in basically it's the both diseases look similar, and it's very difficult to differentiate. The main differentiating fact is that if the patient is developing the morbid hypertension, like the proteinuria before the 20 weeks of pregnancy, we can assume that it's a SLE flare, and we can evaluate with the further laboratory parameters. And usually both the lupus nephritis and as well as the preeclampsia, sometimes it coexists. And the type of the hemolysis in the both conditions are different. Like it's a Coombs positive hemolytic anemia usually seen in the SLE, whereas microangiopathic hemolytic anemia is seen in the preeclampsia. And the evidence of the diseases in other organ also differentiate between these two, SLE and the preeclampsia. However, like the diagnosis of the disease is primarily important in early we pick the disease, like that will be good for the both mother and baby.
Okay. So what about the laboratory test which can be used in differentiating SLE from a lupus flare, Dr. Vinny?
Yeah, ma'am. As we already said, so proteinuria is present in both, but the presence of CAS, especially red white cell CAS, are present in lupus. And also thrombocytopenia to an extent is present in both, but most typically associated in lupus nephritis as compared to, means it will go into HELP and then become thrombocytopenia when it comes to preeclampsia. But in lupus nephritis, usually there will be a coexisting mild thrombocytopenia already present. And also microhepatic hemolytic anemia in preeclampsia is associated with schistocytes in the peripheral smear, which will be absent in lupus nephritis. Commonly elevated liver enzymes also is associated with HELP rather than SLE related. But elevated uric acid is very specific to our preeclampsia. So these are usually the differentiating factors.
So we're talking about flares now. Can you please tell us about types of flares? Dr. Ramya?
Ma'am, the flares can be, it's indicating disease activity. It can be mild, it can be moderate, it can be severe. Very mild ones you might miss because they might tell the rash is a little worsening. Very mild one, very mild arthralgia is what they predominantly tell. In moderate, the arthritis, the non-erosive arthritis will be a little more prominent. You'll get mild to moderate worsening of your counts, and that will be the mild and moderate one, madam.
Dr. Ahmed, what about severe flare?
Yes, madam. Severe flare, when there is lupus nephritis, when there is involvement of the heart and the lungs like pericarditis or pleuritis, and severe hematologic disease like severe cytopenia, pancytopenia, and CNS involvement like seizures or psychosis. And there is a catastrophic antiphospholipid syndrome that is associated with the multi-organ involvement and thrombotic microangiopathy, which has a 50% risk of death in pregnancy.
So treatment of flare is when we usually give immunosuppressants like non-fluorinated oral glucocorticoids, that's prednisolone. Usually dexamethasone is not used for long-term in pregnancy. Can add other immunosuppressants also. Severe flare will require higher dose of prednisolone, like more than 20 milligram per day, like that. And when to deliver these women, usually the ideal time is around 37 weeks, though we think the baby is fully mature at 38 weeks, because as the pregnancy advances, there is more chance that this patient will develop preeclampsia, FGR, and still. So that's a typo there. And there is also analysis have shown that 37 weeks is ideal for this deliveries to prevent stillbirth also with a significant odds ratio. So in this study, we can see as the gestation age increases, preeclampsia, IUD, stillbirth, even maternal death is increasing. So ideal time will be 37 weeks of pregnancy to terminate. Dr. Sabna, what about breastfeeding?
Yeah, so breastfeeding should be is encouraged, and some of the medicines that we use are not compatible, like mycophenolate mofetil and methotrexate. It's not conducive, whereas other steroids and immunosuppressants can be given. Azathioprine may be given, and because the dose is that is excreted by breast milk is said to be very low. So these are the medicines which could be compatible. And hydrochloroquine is obviously one of the safest drug. It doesn't even require the dose adjustment. So definitely it is compatible with breastfeeding, along with the other drugs like steroids, azathioprine, sulfasalazine, and cyclosporine. Then, yeah.
Now, what about drugs not compatible with breastfeeding?
Basically, the drugs which are contraindicated in pregnancy, that has a mild contraindication in lactation too. Can you hear me, madam? Can you hear me?
Yes, now it's
okay. So the drugs which are contraindicated in pregnancy, you should use it in caution in ladies who are breastfeeding too. So the drugs like cyclophosphamide and veclosporin, leflunomide, all these drugs you should use with caution in breastfeeding mothers. And methotrexate, actually, if we use a low dose methotrexate, it may be allowable as per the maternal indication in breastfeeding mothers. But that should be discussed. Definitely, there should be a group discussion, a multidisciplinary team discussion before we continue these drugs during pregnancy and after pregnancy with the pediatrician too.
Dr. Vinod, about postpartum management. Should we follow up?
There is an increased chance of SLE flare in the postpartum period, especially the 4 to 6 weeks. So If the delivery is the pregnancy was uncomplicated and it's an uncompleted delivery, we should undergo we should advise for the disease monitoring by 4 to 6 weeks. And if during the delivery the disease activity is severe, then the monitoring is individualized depending on the patient disease activity. And after this, after 6 weeks and all, we can advise as of non-pregnant women, that's every 3 to 6 months.
So, Dr. Tangu, I think we have already reached 30 minutes. Now we would like to hear from our experts, Challama Madam and Dr. Shashirega regarding the SLE. Challama Madam.
A few questions are there in the question and answer session.
Okay.
That box, not session, the Q&A box. So we can.
Where is Challama Madam? Would you like to?
Mundas, are you stopping with SLE only?
No. I want your comments on SLE, Madam, before we move to the next.
Okay. Regarding SLE, all the.
Allows me to continue or we will stop because there is one more panel.
I thought you are stopping with. Am I audible?
Yes, madam. Yes, welcome, madam.
I thought you are stopping with SLE because already time is over. And also regarding the SLE, all the panelists have done very well, and almost everything is covered by all the panelists. And I only want to emphasize about the diagnosis of SLE, especially with flyers, and it is complicated with preeclampsia. So, we know the maternal and fetal morbidity and mortality are very high in preeclampsia. In added with SLE, there is more complications, and especially the termination of pregnancy, as you said, is very important. It should be terminated by 37 weeks because by terminating at 37 weeks, there is decreased rate of stillbirth, low birth weight, and maternal and neonatal complications associated with preeclampsia and SLE. One more point I want to add is that apart from the postpartum, in the postpartum period, especially from the flares, there is increased chance of venous thromboembolism. Venous thromboembolism. So we should be more alert about the venous thromboembolism in the postpartum period. And regarding the medication, etc., so all you have mentioned, Suma has mentioned about the drugs used. Azathioprine also is used, but I think it's not contraindication in breastfeeding. But hydrochloroquine is the drug of choice. And regarding the these diseases, the most important thing is that counseling, pre-pregnancy counseling and planning. And if the patient is in the active phase, advise the patient not to conceive in the active phase of SLE. And also about the pre-pregnancy counseling, antenatal care, and also about the planning of delivery, and also about the intrapartum management and postpartum management and counseling regarding contraception. It's all important, but almost everything is covered by your panel members. Congrats to all panel members. Thank you.
Thank you, madam.
Just one question.
Chat box. Thank you, madam.
In the chat question and answer box, that is to clarify regarding the cutaneous manifestations in the neonatal period.
Dr. Vinod, you want to take that?
The cutaneous manifestation usually seen in the neonate is erythema rashes, ma'am. It is self-limiting and usually resolves by its own by the 6 months of age. We should care the baby with either with protective cloths or protective emollient for the baby. Otherwise, or else there is no much treatment for the cutaneous manifestation. If the baby is affected with other complications such as hepatosplenomegaly or hemolytic anemia in the baby, then we can give a chance of we do the IV the steroids and IV immunoglobulin as a role in that.
And one more question in FGR, Dr. Suma. Late onset FGR, but growth progress is there. That means serial growth is there, but it is FGR and isolated MC abnormality. Repeated scan show it, but suddenly the MCA improves.
That's what, madam. As sir already told regarding that.
Possible sterile or really?
Have to confirm that it is really abnormal. What happens is that sometimes we get a transient abnormality in MCA Dopplers. So we have to make the patient wake up, have something, get a walk done, and again recheck that it is abnormal, really abnormal, whether it is really abnormal. So the abnormal MCA becoming Doppler is very unusual. So we have to make sure that our reporting is correct. And but with a normal growth centiles, at times MCA can go abnormal. So we have to have a watch on the patients. But ideally, if the baby is growing well and everything is normal, and if MCA PA is only at the abnormal side, then usually there can't be much of a problem.
Look at the CPR also.
Yes, madam. CPR. If CPR is
Effect
normal.
of aspirin if uterine artery PA is high, or if it is high, what is it?
Madam, that's a question from previous session.
We have to give aspirin.
I think we can continue with the pan.
Yes, madam.
You do the proper preeclampsia screening and go according to the FMF risk scoring, or you just give aspirin when the uterine artery PA is high. Is that the question I did?
Yeah, that is answered, madam. Sini sir answered it.
Okay.
In low resource settings, we can do.
So all these questions are already answered. Okay. Any precautions in labor? Like it depends on the fetus, if it's a preterm delivery or FGR, accordingly. Otherwise, there is no precaution. But if the patient is having lupus nephritis, other comorbidities like high blood pressure and all that, we have to take that also into consideration in the patient. What about steroids in labor? Steroids in SLE, sorry. Steroids, she's already on steroids, right? So most of these patients could be on steroids, especially if they are having flares. And the drug of choice is prednisolone. Tangu, on off. It is time is 8:30 almost.
We can continue. We can continue.
Okay. So the next problem that we have is antiphospholipid antibody syndrome, where we know there is thrombosis. It can be venous or arterial thrombosis. It can be small vessels. It can be large vessels. It can be anywhere in the body. So it can be a primary antiphospholipid syndrome, or it can be a secondary also. And there are actually different types. Dr. Ramya will briefly tell about this type. Ramya, please make it brief.
Yes, ma'am. You have thrombotic APLA, where you have venous or arterial thrombosis, or obstetric APLA, which has adverse pregnancy outcomes, or microvascular APLA, where small vessels are involved in thrombosis, or a catastrophic APLA, where multiple small and medium vessels of multiple organs are simultaneously involved, leading to high mortality.
Yeah. A diagnosis of APS, antiphospholipid syndrome, that is the difference between antiphospholipid syndrome and antiphospholipid antibody, that is the antibody is the laboratory evidence of this antiphospholipid antibodies like lupus anticoagulant, beta-2 glycoprotein, and anticardiolipin antibodies. While in APS, it is associated with at least one of the clinical evidence of thrombosis like venous thrombosis, arterial thrombosis, and pregnancy morbidity. And in the setting of this persistently positive antiphospholipid antibodies, and it should be present in at least 2 separate occasions, 12 weeks apart.
Dr. Sabnam, when do we suspect APS?
Yeah, when we have obstetric APS characterized by it's a bad obstetric history basically. So there may be a pre-fetal death, that is before 10 weeks. Then there could be fetal death between 10 to 15 weeks, which we call early fetal death, or between 16 to 34 weeks. Either it could be a fetal death or it could be an adverse outcome due to chronic placental insufficiency, severe IUGR, either an abruption or severe severe preeclampsia. And preeclampsia with severe features itself, that is also an indication that it could be obstetric APS. That is all the systemic involvement which are characterized in severe preeclampsia. So it could be liver dysfunction, it could be renal dysfunction, it could be a headache. The patient may present with a headache which is intractable, not responding to medications. There could be thrombocytopenia, there could be abnormal Doppler. These are things which we come across in our daily practice. There could be abnormal, when we do a regular NSTs, follow up with NSTs, they could be abnormal. And even after an IUD, suppose we do an autopsy, there can be seen vascular malperfusion effects seen in the placental histology. So all these factors could suggest obstetric APS.
So Dr. Suma, I think Ramat has answered that.
Yes, madam.
Yes.
It's already covered. So only thing, if you get an IUD at 4th month, or if a lady lands up with an early onset FGR, then definitely go for an evaluation of autoimmune diseases. And along with the early onset FGR, if there is an early onset
Are associated with higher risk of adverse obstetric outcome. Definitely lupus anticoagulant, even if it is moderately high titer, is associated with adverse outcome. But some patients do not have lupus anticoagulant in them. When there is an IgG anticardiolipin antibody, beta-2 glycoprotein, they are also having higher risk of adverse outcome. And triple positivity means when all three are positive, lupus anticoagulant, anticardiolipin antibody, beta-2 glycoprotein, when all three are positive, studies have shown in 750 primiparas that only 30% of these patients could end in a live birth when all three are present. Dr. Vinod, the prenatal investigations.
Ma'am, these mainly include the APLA profile, which includes the anti-lupus lupus anticoagulant, anti-cardiolipin antibodies with IgG and IgM, and the beta-2 glycoprotein with IgG and IgM category. Then we supposed to evaluate the platelets, and you monitor for the urine creatine, protein creatinine ratio for the development of any early preeclampsia, which is most common in APS. And we should monitor the liver function test in the patients, and we should also see for the complement levels in the patient, and the anti-Ro and anti-La antibodies, as I previously told, for the when we suspect the neonatal lupus, the presence of these antibodies will indicate the presence of neonatal lupus. For these are the evaluation to be done just like in SLE for the patient with APS, suspected APS.
For the ultrasound examination, we have to do the dating scan in all patients and growth scan, because we know because of this placental thrombosis, the higher risk of FGR is there. And biweekly NST and biophysical profile also starting from 32 weeks onwards, because these features have increased risk of antepartum fetal demise. Coming to the management, Dr. Vinod.
Ma'am, this is settled into like if there is a previous history or not, like a thrombotic APS with or without like obstetric APS. The antepartumly we should give the full therapeutic dose of the low molecular heparin with the low dose aspirin, and in postpartum period we can transit the patient to the warfarin, oral anticoagulants. In in clinical setting with only obstetric APS, prophylactic dose of low molecular weight heparin can be given, that is like up to like 40 milligram per 40 milligram daily. And so I forgot to inform that the therapeutic dose ranges from like 1 milligram per kg twice daily for the thrombotic APS. And in cases of persistent APL with history of adverse pregnancy outcome but not meeting the APS as such, in that cases we can go with the low dose aspirin. And postpartumly we should give the for vaginal birth we can continue with the low dose aspirin for 6 weeks, and for the patient undergone for the cesarean, for them we supposed to start the low molecular weight heparin for the at least 6 weeks.
And Dr. Vinay, what about the timing and route of delivery, etc. in these women with?
Yeah, so madam, as already mentioned, all this APLA syndrome definitely has a high risk for preeclampsia, fetal growth restriction, and all other obstetric complications. So depending on that, we will decide the timing and route of delivery. So suppose there are absolutely no complications, which is very unlikely, and the patient is on low molecular weight heparin, ideally we can continue it up to 24 hours if it is low molecular weight heparin, usually at 36 weeks we convert it into unfractionated heparin, and prior to 24 hours prior to the vaginal delivery is the time to ideally stop it, especially if she has a history of a thrombotic event in the previous pregnancy or in the current pregnancy. If she's a high risk, she should be continued on unfractionated till 24 hours prior to a delivery. And the low molecular weight, the low dose aspirin can be continued till 36 weeks definitely, but in high risks it can even be continued similarly, means up to 3 days prior to inducing. So it is very important to titrate the dose and monitor the patient with an NST, baby's biophysical profile, and monitor even intrapartum very closely. Immediately after delivery also, like Vinod just said, 6 hours after normal delivery or 12 hours after cesarean section, the anticoagulation has to be restarted in a high risk patient.
Thank you, Vinny. Thank you. So that covers APLA also, antiphospholipid antibody syndrome. So Chellama madam and Shashirega madam would like to say something regarding the management of antiphospholipid antibody syndrome.
പറഞ്ഞോട്ടെ. Hello. Hello.
Yes, madam.
Yes, ma'am.
ശശിരേഖ ഇല്ലേ?
ഉണ്ട്
എന്നാ പറഞ്ഞു.
It's there. So congratulations, almost all covered, madam. In detail, it is very informative.
Yes. And Mundas?
Yes, madam, I'm here.
Mundas, again, all the panelists are covered, especially the theoretical part, and also diagnosis and the clinical diagnosis and the biochemical diagnosis, etc. And the most important is the most of the women may be traumatized because of their recurrent abortions or recurrent pregnancy loss. So the psychological support is very important, that I should highlight about that. Apart from the proper antenatal care and also about the anti-thromboprophylaxis already I have mentioned in several CMEs. And what about Dr. Vinod? What about the warfarin?
Ma'am, like if you want to start the warfarin, we can the usually low molecular weight heparin in APLA. We start as soon as we find the cardiac activity, and we can switch over to warfarin after like 12 after 12 completed weeks.
12 weeks
and then we can resume after we should stop 34 weeks.
Again, restart at 36 weeks. Heparin should be started at 36 weeks. But the only thing is that many of the consultants usually give heparin, especially heparin, especially if it is already there is recurrent pregnancy loss, or it is the clinical and biochemical diagnosis of APLA is there. And also the most important is, as Suma said, it is a time for termination of pregnancy, and also the management of labor is also important, and also switching over to the anticoagulant before delivery and after delivery, especially after cesarean section. And if the pregnancy itself is a thrombogenic condition, so we have to start heparin. Okay, that's about, I think it is almost all covered. Kundas.
One question, ma'am.
Mumtaz, can we?
Yeah, I've stopped sharing already because I think that's already 45 minutes.
Yeah, we are running short of time.
Yeah, that's what.
I would like to thank you, Mumtaz.
Just my sincere thanks to all.
Thank you. Tangu, one or two minutes.
Okay, ma'am.
There are a lot of autoimmune diseases, especially which occurs in the reproductive age group, and it may be associated with pregnancy. Only two we could discuss in detail. There are other conditions like thyroid disorders, Hashimoto's disease, and Graves' disease. It's all important because it can affect the outcome, pregnancy outcome also. That is also should be thought of during when discussing this one. Other thing is the ITP. ITP again, it is another common complication we are seeing during pregnancy autoimmune disease, and also rheumatoid arthritis. Rheumatoid arthritis only problem is regarding it is not affecting the baby, but only problem is regarding the delivery because of the problems of the hip and also that is a lumbar spine also. And another condition is the myasthenia gravis, where it is a weakness of the muscles. And again, the problem is only regarding the delivery because the weakness of the muscles, and so sometimes it may be assisted supportive delivery may be needed, like vacuum or forceps. So, the Crohn's disease are there, Addison's disease, so many diseases are there. But regarding the pregnancy, SLE is very common, ITP, and also thyroid disease. I think these three could be covered in detail by our panelists. Congrats to all the panelists and the moderator Mundas. Thank you.
Thank you. And
Thank you, ma'am.
panelists, for your wonderful performance. And thank you, Tanku, for the opportunity.
Thank you, ma'am, for the valuable points. Let us move on to the next panel. Actually, the next panel discussion is on the critical care in obstetrics. And the moderators are two stalwarts from Calicut Medical College. The main moderator is Dr. Sajala Vimalraj. She's a professor in obstetrics and gynecology in Medical College Kozhikode, and she's also the vice president of Calicut Obstetrics ONG Society and the treasurer of the National Society for the Studies of Trophoblastic Diseases of India. And above all, she's so much interested in academics and research. And the co-moderator is Dr. Bindu Vijaykumar. She's an associate professor at Medical College Kozhikode. Is an vibrant obstetrician and gynecologist. So over to you, ma'ams, for the interesting topic.
Yeah, thank you, Tangu, for the invitation, for including me as part of this webinar. It's really very well managed, and that's no less because of all your efforts. Like somebody said earlier, are you all studying? Are you all ready? So all those inputs, timely inputs, geared us all into activity. And today we are here with the panel. So we have a eminent array of panelists. We have Dr. Sridevi Binu, she's consultant SMMs Cannanore. And we have Dr. Lakshmi Mohan, who's assistant professor SMMC Chennai. We have Dr. Sophia, who's consultant Malabar Hospital Manjeri. And there's Dr. Remya J, who is a star of our panel because we are dealing with critical care and all the others are obstetricians, and Remya is an obstetrician plus an internal medicine specialist, a combination that is hard to beat. And we also have Dr. Khadija Sharon, who's consultant Vinayaga Jyoti Hospital, Manandawadi. Now, we have as our experts today two eminent faculty, Dr. Omana Madhusudanan, who's president Wayanad OBG Society and HOD OBG Vinayaka Hospital, Sultan Betteri, who's always there with her gentle smile, putting us along all these journeys. And there's Dr. Hari Prasad, senior consultant OBG from Fatima Hospital and Kim Srichand Hospital, Cannanore. So without much further waste of time, we'll go ahead with the panel. Now, as we all know, about 3 to 8% of our parturient women may require critical care, and 2/3 are unanticipated, which is where we obstetricians need to be on our toes. So here today, what I basically plan to discuss is not the entire gamut of critical care, because then we have our intensivists, we have our emergency and critical care friends, we have anesthesiologists to help us with it. But as an obstetrician in the labor room, most probably alone, at the time when the patient collapses or goes in for this critical event, what should we do at that time? That's all that we are going to discuss in this half an hour. I hope to finish within half an hour. So what happens is the acute insult mostly tides over, and then there are the sequelae which come over the next few days. So the multi-organ dysfunction that sets in. So what we need here is a care without walls. The obstetrician, with the nephrologist, the gastroenterologist, all of them involved in the care of the patient, and that is what will help the woman. Now, as I said, it's a specialized management of the critically ill patients with interdisciplinary care, which is most important. And most often we have our critical care required in patients with hemorrhage and hypertension. So these two topics, eclampsia and PPH, are discussed galore all over. And so I've decided to actually keep it at bay because in half an hour, we may not be able to cover everything. The other reasons why a patient might need critical care, as we know, sepsis, cardiomyopathy, anaphylaxis, trauma, gastrointestinal disorders. So we'll have a general overview as to what to do in these patients. So whenever a patient goes in for a critical event, we need first to recognize, we need to respond immediately to the situation, and then we need to augment our level of care. So level 2 or level 3 critical care in an HDU, a high dependency unit, or a critical care unit. Now, what makes our task very difficult, uphill task, is because of all the physiological changes which occur in pregnancy. The changes in the cardiovascular system, the respiratory system, the upper airway edema, which makes intubation difficult, respiratory alkalosis, alteration in renal function, GI function, altered drug metabolism. All this makes it difficult actually to manage the patient. And so we need to have an idea about what exactly to do. So we go over to the first case. Now, this is a 29-year-old Gravida 3 Para 2 Living 2 with a first FTND 7 years back. GDM, well controlled, comes in spontaneous labor at 38 weeks. She progresses rapidly. She shifted to the second stage. There, she almost at full dilatation. That's why she shifted to the second stage. She has a seizure. Immediately, a vacuum is applied and a 3.2 kg baby, slightly asphyxiated, is delivered. Then there is sudden saturation fall, hypertension. There's mayhem in the labor room. The SpO2 was in 85 in room air. The BP is 80/60, so there's hypertension, there's tachycardia. The GC score is E2, M5, B2. The pupils are equal and reactive. Now, Dr. Sridevi, can you be with us first? What would be the causes of acute collapse in this immediate postpartum period? Can you just highlight that?
Hello, madam. Am I audible?
Yes, you are.
In this patient, the cause could be amniotic fluid embolism or pulmonary embolism, or it could be eclampsia. The maternal collapse is a very rare but life-threatening condition. There are reversible causes for that. For quick memory, there are 4 H's and 4 T's. The 4 H's are, one is H hypoxia. It can be due to pulmonary embolism, periportum cardiomyopathy, anaphylaxis, pulmonary edema, eclampsia, intracerebral hemorrhage, and the second is hypovolemia. It could be due to massive hemorrhage, or it could be rupture of the splenic or hepatic artery. It could be due to hypothermia and hyperkalemia. These are very rare, but it is also mentioned, which stands for H. Then there are 4 T's also. The 4 T's are thrombus. It can be amniotic fluid embolism, air embolism, pulmonary embolism, myocardial infarction. The toxins, it could be local anesthetic, opioids, illicit drugs, self-harm, magnesium tranexamic acid. Then another T is tamponade. It can be due to trauma and tension pneumothorax. These are the 4 H's and 4 T's which are usually attributed to maternal collapse.
Yeah, so what we need to know is we need to have this basic list. There's another easy mnemonic which goes A, B, C, D, E, U, P, S. And we can use all these to just run through our mind what could be the causes. And then we have to come back to our scenario and see what could have happened in this patient. So at full dilatation, there's a seizure and then there is collapse. So in this scenario, what could be the causes that you narrow down to, Dr. Sridevi?
It could be amniotic fluid embolism.
Yeah, or it could even be because it's just soon after delivery. So it could be a rupture, or she's had a seizure. So it could be eclampsia. So you have to review, was there hypertension? Is this likely to be eclampsia? Was there some traumatic delivery? Is it rupture? Okay, so now as we go ahead, what we want to know, the cause can actually wait. What we need to do when the patient collapses is go ahead with the immediate resuscitation. So Dr. Sharon, can you tell us what are the initial aspects of resuscitation?
Yes, ma'am. The initial aspects of resuscitation, the first thing what we have to check is we to look for the airway, whether the airway is patent. We have to go for head tilt and the chin lift. And if the patient is still not breathing, we have to start chest compression. We call for help. We start her on the chest compression. We place the hand over the center of the chest. The compressions are given at the ratio of 30 we give 30 compressions followed by 2 breaths, rescue breaths. The rescue breaths we can utilize the bag and mask ventilation. The rescue breaths should be given at a rate of over 1 second period. We have to give the rescue breaths. And suppose the lady is pregnant, what we have to do is we have to go for the continuous left uterine displacement. The uterus should be displaced, and still not revived, we should even be going for a resuscitative hysterotomy. And being such an acute event, have a teamwork here. When one set is actually dealing with the resuscitation, the other set should actually try to find out what is the cause for the collapse and try for the corrective measures.
Exactly. So what situation we have described here is where there's saturation fall and there is hypotension and tachycardia. There's not exactly a collapse. But if the patient is unresponsive, then you need to check for the response, check for the carotid pulse first, as we are trained in all our PPMD and ORRT meetings, and start with the cardiac high quality CPR. Okay. Meanwhile, you check for the airway, breathing. So all these things have to go hand in hand, and you are assessing for the cause. So the first thing we look for usually is atonic PPH as a hand on the uterus. Is there bleeding? Okay, so that list has to be revised. So only if we have constant drills in our labor room will we be able to actually have a good, a very smoothly oiled response to this situation, right? So what are the initial investigations that you would do, Dr. Sridevi? This patient is here, she's collapsed, somebody is starting a line, somebody is putting in a catheter, somebody is looking whether there are any, traumatic PPH and all. What are the initial investigations that you would like to send?
Resuscitation and investigation should be going together. So the usual investigations, we usually send complete blood count, liver function test, renal function test, coagulation profile, fibrinogen test, fibrin degradation products, all these blood investigations. Then along with that ECG, echogram, and imaging, even ultrasound should be done along with it.
So the bedside clotting test is very important, because whenever you have something like a rupture or you have amniotic fluid embolism, DIC is going to set in soon. So in this situation, you would like to know whether the clotting, especially if she starts bleeding, whether the clotting is a problem. And one of the a good bedside tests, the clot retraction test. Also, if you have the facility of thromboelastography, that would be good. Dr. Bindu, you want to add something here? Okay. So thromboelastography, when you do it at the bedside, it will tell you what is the exact problem, whether is it in coagulation, is it the fibrinolysis, and it will tell you what transfusions to give. So most blood banks can have, or you can have it at the bedside in your with the patient. But of course, even at IMCH Calicut, we don't have the what do you call, the luxury of having a TEG. So we generally go by the clot retraction test, and we go depending on the rest of the scenario. And the point of care ultrasound, Dr. Sridevi, is very important. What could you pick up on the ultrasound?
Yeah, point of care ultrasound is a bedside procedure. It is a screening one. It can be usually done by a clinician or obstetrician. We get rapid diagnostic test. We can do it rapidly, and it will help in clinical decisions. So the conventional imaging, going to ultrasound, it will take time, and it might delay our management. So the portable ultrasound will help us to make the decisions earlier.
So you look for hemoperitoneum, so you can judge whether there has been a rupture, okay? Or you can, if you have the anesthetist with you, they can have a look at the IVC. They can do a screening echo with the point of care ultrasound. So all these will help you come down and try and narrow down the diagnosis. Now here what happens, as you stabilize and you do all these things, the patient starts bleeding profusely per vagina. The hand on the uterus appears to be contracted. The urine, however, is a little blood stained when you put in the catheter. So now can you narrow down the diagnosis, Dr. Sharon?
Probably this could be due to trauma. It could be traumatic, or it could be due to DIC. And if she had been induced, there is one more chance, that is there could be a lower segment PPH, atonic PPH can also be the reason.
Yeah, so these are the things that you would like to rule out. We've done a vaginal exploration. We didn't see any lacerations. We didn't see any cervical vaginal lacerations, no tears in the fornices, no colporexis. So, so that means it's not traumatic PPH, then it's likely to be DIC due to amniotic fluid embolism, especially the setting, right? At full dilatation, soon after she progressed very rapidly, and at full dilatation, she had a seizure and then she collapsed. And then now she started to bleed profusely. So this is a typical clinical scenario where we must have a very high index of suspicion. So now that you have to take care of the DIC. So how would you go about that? How would you manage the transfusion? Dr. Sophia? Hello, Dr. Sophia is there?
Yeah, madam.
Yeah.
Am I audible, madam?
Yes, yes.
Good evening, all. It's a massive transfusion protocol is a structured medical procedure involving a team approach used to rapidly provide a large volume of blood or blood products to a patient who is experiencing a massive hemorrhage. It is defined as a replacement of a more than 10 units of PRBC in 24 hours, or it could be a more than 3 units PRBC in 1 hour with an ongoing bleeding like this patient, and or it is a replacement of more than 50% of the blood volume with 3 hours. We should activate the massive transfusion protocol called when the shock index is more than 1. That is, the patient is having tachycardia of more than 120 as we see in this patient, and also the blood pressure is less than, systolic pressure is less than 80. And the patient is profusely bleeding, and also there is the focus showing there is hemoperitoneum or there is any hemoperitoneum. Then we should, the massive protocol, it is, as we already discussed, it is a team approach. We should alert the team, that is the lab and the obstetrician, the blood bank, and the anesthesia team, all should be alerted. And we should have an array of the blood. That is, we should, in the one protocol, one pack of MTP, it consists of 6 units of PRBC, 6 units of FFP, and an FRSS pack, that is 6 units of platelet. We may consider cryoprecipitate or the factor 8 as well.
Yes. So although we previously went on a 1:1:1, it is still a good
1:1.
rule to be based on. Nowadays, they say that you should be replacing, if you're, depending on what the hemoglobin level is, you give your PRBC, depending on your platelet level, you decide how much. And that is where the thromboelastography sometimes helps you. Now, what are the problems when you give this massive transfusion?
Yeah, it's very cumbersome. That is, if we are transfusing more and more PRBC, FFP, platelet, and all in a serial order, that it will lead to, especially the electrolyte imbalance is the main thing. That is, the patient may go in for hypocalcemia, hypomagnesemia, hyperkalemia. There may be chance of metabolic acidosis. There is high chance for hypothermia, and also transfusion associated lung injury, and also transfusion associated cardiac overload. And also there is a high chance for dilutional coagulopathy, that is platelet is depleting. Sometimes platelet clotting factors are depleting. There is high chance for dilutional coagulopathy by itself. And also there is high chance for infections, and so there is maybe a chance for multi-organ dysfunction, or there is a chance for SIRS also.
Yeah. So we must check, we must know when to give diuretics at this time, when you're giving many units of blood. You have to have a look at the CVP, the blood pressure, and decide about that. Plus, you need to give calcium gluconate when you transfuse many. And so somebody needs to keep a track of what is given, what is not given. You repeat your electrolytes, repeat your investigations, and see what needs to be corrected, which is very important, because otherwise you'll be causing more problems than you are solving. Would you like to give tranexamic acid, Dr. Sophia?
Yeah, madam, it's really indicated. It is an antifibrinolytic agent, and it inhibits the breakdown of fibrin. That is, the fibrin is the main thing that we want at that point of time. We can arrest the bleeding, we can save the patient also. And we should take a caution that if the patient is having acute thrombosis event, or if the patient has a history of thromboembolic accidents, we should not give. And also, if a patient is having severe renal failure, we should not give tranexamic acid.
Dr. Ramya, would you like to add anything here?
Madam, when you talk about massive transfusion protocol, you want to know when to trigger it. We don't want a retrospective diagnosis, right? You're telling 10 units for 24 hours. I want to know whether now I have to trigger the transfusion, right? So if you
she
see
did
a
say there is a
patient,
shock index. Yeah, it's more than one.
yeah, yeah.
Yeah.
It will be
Yes,
a
this,
better
this
definition than other definitions. And whether you give tranexamic acid in setting of DIC, it is not indicated. It might be harmful.
Yes, exactly.
Actually, that is
Yeah.
latest case. If your patient has
Harmful.
not gone into DIVC, it is just hemorrhage, then you can give. Otherwise, once DIC sets in and you have, they say even hematuria, sometimes the thrombosis can block and cause obstructive uropathy. These are very well, there are studies about it in trauma patient because this massive transfusion protocol actually came in trauma, and now we are using it in non-trauma things. And regarding use of this thing is this patient is delivered, you should ensure that the temperature, no, that's what we were talking about mainly. You have to remove all the wet things. You have to keep the patient warm. You should give warm fluids. You should ideally warm your blood and blood products and give. And coming to the dilutional part, which was told, I think the idea of massive transfusion protocol is to prevent dilutional coagulopathy induced by your fluids. That was the idea. And this 1:1:1 still holds good. You can give, there is no order that you have to give 6:6:6. You can give one of FFP, then give one of platelet and one of, that's how you do. It is not that you give 6 pack of, like, that is what you have to know.
Yes. So I think one good thing Dr. Ramya said is remove all those wet clothes as and when there's continued bleeding. That has to be looked into. We all taught that, and whenever there is an initial bleeding episode, give your tranexamic acid fast, maybe repeat within half an hour. But once a patient sets into DIC, then you should be careful. You should not give tranexamic acid. So that is another point that we need to note. Now, what is the role of hysterectomy, Dr. Sridevi? This patient now, she's bleeding profusely. She is having DIC. You are trying to correct the coagulopathy. What would be the role of hysterectomy?
In this patient, coagulopathy should be corrected with FFP or cryo. The coagulopathy should be corrected first. So if the coagulopathy is corrected and still profuse bleeding is there, the multidisciplinary that approach, that involvement of the senior obstetricians and senior ICU consultant and the close counseling with the husband or family members is very important before taking a decision. And also timely decision also is important. Late patient going for late features and then going for hysterectomy won't be helpful. We have to take the decision at the earliest also. It can be double-edged weapon also. The patient can go for death intraoperatively. So the decision should be appropriately done, and it should be very cautious in this patient regarding hysterectomy.
So whenever there is coagulopathy, you should ideally correct the DIC. Try and correct the DIC quickly as early as possible. As somebody said, like we said earlier, you need to give cryoprecipitate. Generally, we've heard 2 units of cryoprecipitate or 3 bags of cryoprecipitate, which is not enough. If the fibrinogen is less than 200, you need to actually, start with 6 and 10 bags of cryoprecipitate and go ahead as required. And when the coagulopathy is getting corrected, if you still have the uterus by then becoming atonic, and you want to control the source of the bleeding, you might decide to do a hysterectomy. Again, double-edged weapon, because as you open up, if the DIC is not corrected, you're going to have troublesome bleeding from all over the place, and it's going to be very difficult for you to actually finish the procedure and come out because of all the multiple oozing. Of course, you need to put in a drain and be careful and generally continue with the correction of the DIC. Now, what about inotropes and ventilatory support? Dr. Ramya, can you give us a brief overview what is required for us as obstetricians? You will be there definitely to manage it, but...
See, I think whatever is the cause of the shock, whether you're dealing with the hypovolemic or cardiogenic or a septic shock, first and foremost is norepinephrine. So all of us should know about norepinephrine thoroughly at the back of our hands. And at what conditions you deal, if it's hypovolemic shock, you should replace only fluids, and blood. And the role of these inotropes and vasopressors come only when the BP is extremely low and you want to maintain some perfusion pressure. That is one thing. Suppose I'm dealing with cardiogenic shock, madam, you just told about amniotic fluid embolism. right? Probably that patient has gone in for severe pulmonary hypertension and right ventricle has become hypokinetic and failed. At that time, I'll start the inotropes and vasopressors early. That will be norepinephrine followed with dobutamine. And then the rest of the shocks, depending on the underlying conditions, we will decide whether it's fluid or inotropes first. And coming to ventilatory support, you just want to see whether your patient is alert, is able to handle the secretions, and how hemodynamically stable that patient is. If the patient is hemodynamically very unstable, that patient has to be ventilated, right? If the patient is okay, conscious, alert, is able to maintain the secretions, maybe you can even try high flow nasal oxygen or non-rebreather mask. It depends, because you have to maintain the saturation, right? And if you're wanting to do ventilation and the patient wants non-invasive ventilation, you should understand that NIV can work if there is pulmonary edema to reduce the congestion, but at the same time, it will drop the BP. So majority of critical patients land up with the ventilation, and that becomes safer for them because invariably they will be having metabolic acidosis.
Okay, thank you. So basically with amniotic fluid embolism, even in the last Why Mothers Die, which has just come out, over the last 4 years, I think there were 33 cases of amniotic fluid embolism resulting in maternal death. So it is something that we need to be really on our toes about. Diagnosis, clinical, high index of suspicion, high quality management initially itself, where you look at all the aspects. So I think we've covered a little bit of what we can do in the labor room, and we move over to our next case. Dr. Bindu, will you take over?
Yeah, I'll take over. First of all, let me thank Tangu for making me part of this panel. And I would like to appreciate the fact that ma'am said Ramya is the star of this panel. Because, I mean, once we finish off with a cesarean or an evacuation of a products of conception or a hysterectomy, you have to take over. Whatever we do, we cannot reach your level of expertise. So sepsis, as ma'am said, this is again one of the most important cause for maternal mortality. And in spite of whatever, we've been able to bring down the deaths due to hypertension and PPH, but sepsis, it's still there even because we don't have more antibiotics. So we have to actually prevent sepsis or recognize sepsis very early. That's the only thing I think we can do. Because no new antibiotics are coming up. So we'll start off with the case. This is a 23-year-old second gravida who had an uneventful antenatal period, who comes at 34 weeks with a history of preterm premature rupture of membranes for 3 days. And now she's reported to the casualty after 3 days with fever and abdominal pain. So Sophia, Dr. Sophia, so could you please elaborate on the features of chorioamnionitis? Because any patient with PPRM, this is the most, important complication that a gynecologist is on the lookout for. So what are the features which should prompt you to an early action?
As we know that this patient is a second gravida. She is only 23-year-old with an uneventful antenatal period. She came with PPROM. That is the main crux of the event. 34 weeks, she had a break in the membranes. So, and it is for 3 days, and she developed fever and abdominal pain. These are the main features that are going to have the patient to be in a sepsis, maternal sepsis. If the patient is having is ruptured her membranes, and if we did a multiple PV, that is again another cause for the increase in the chance of sepsis. And also if the patient is having fever, and if previously if she is having any vaginal infections like bacterial vaginosis or any sexually transmitted diseases, and if she's having any comorbidities like diabetes or anemia, the chance of infection is more in this patient. And we have to look for any liquor, that is if she is having any PPR, the foul smelling liquor, or if it is meconium stained or something like that.
Okay, so basically any patient who comes with a rupture of membranes, you either you go for an expectant management or you terminate the pregnancy. But patient who's complaining of a fever, an abdominal pain, a uterine tenderness, a maternal tachycardia, and a fetal tachycardia. These are usually 5 points which will point towards a diagnosis of chorioamnionitis, even though all of these may not be present always. So when you find this kind of patient and that focus of infection is that uterus, that pregnancy in the uterus, the next thing what you want to do is, ma'am, can you change the slide? You need to make her deliver. So can we make her deliver, or should we go for a direct cesarean section? That depends upon the scenario. If she's remote from, if she's in labor, you can definitely make her deliver. If she's remote from labor, you will have to take her for a cesarean section. And this lady underwent an emergency CS with a bilateral uterine artery ligation for suspected chorioamnionitis. The baby was stillborn of 1.7 kg. It was scanty liquor, and the placenta and membranes were removed with difficulty, which was not foul smelling. Now, Dr. Sophia, what precautions would you like to take when you're doing a section for such a patient? I mean, you're opening up her abdomen for chorioamnionitis.
Yeah.
It would have been better if she had delivered vaginally, because then the infection would have been contained within the uterus. But then probably she's remote from term, so her cervix would be unfavorable.
Yeah,
So
if the cervix is unfavorable and the patient is if there is a chance for deterioration of the maternal condition, we should definitely go for a cesarean section. So we should make every step. We should be very careful not to be harm the patient, not to harm the patient. So like our procedure will not make her more infectious. Like that, before taking the patient into the operating room, we should get an informed written consent and about the state of the patient, and what are the risks and what are the benefits that if we do a section to this patient for the mother and for the baby. And we should also send necessary lab investigations before taking this patient into the OR. And we also do a thorough cleaning and hair clipping and skin preparation before making her in for the section. Cleaning with a chlorhexidine or povidone iodine is indicated, and administer broad spectrum IV antibiotics prior to the incision. And we should be very careful not to spill this amniotic fluid during the cesarean section. And we should take out after delivering the baby, we should take out the membrane and the placenta with caution, and we should not spill it anywhere in the abdomen. And we should send this placenta and the membrane for culture and sensitivity.
The most important thing, once you have suspected, would have been started on birth and antibiotics. Just like any other section, all the aseptic measures have to be followed. But most important thing is that when you open up the abdomen, you should get the tissue or specimen for a culture and sensitivity. And when you're getting a specimen from the placenta, don't send the placenta as a whole to the microbiology department. You should take swabs from the inner of the membranes. And then the liquor can also be taken for culture and sensitivity. So since this is a patient who is likely to go in for a sepsis, because this is one of the most important factors for a puerperal sepsis, what would be your post-operative orders?
1 minute, Bindu. I think your volume has gone down a little bit. Just see if something has gone wrong. Also, one thing I would like to add is very good cleansing of the vagina with betadine before taking up for cesarean section. It should be followed in all cases, and especially so in chorioamnionitis.
Is it okay now, ma'am?
Yeah,
Audible?
now it's okay. Yes, yes.
Yeah.
So what are the
post-
what I said about the swabs, was it audible? That taking out
Yes, yes.
swabs from the
No.
membrane, in
I
the
think you
aspect
can
of the
just-
membrane. Yeah,
Yeah.
you should not send the placenta as a whole to the microbiology department. You should take swabs from the inner surface of the membrane. And you can take the liquor also for culture and sensitivity. It's very important, because tomorrow this patient is going to, even become worse. So you might have to change your antibiotics according to the culture report. So that's very important. And post-operative orders, Dr. Sophia, would it be like any other section?
No, madam.
Yes.
We should monitor the patient more aggressively so that she don't going for a sepsis.
So this
we should
lady actually,
monitor.
this
Madam?
lady on this lady on the second day, she was a little disoriented. She was febrile. She's tachycardic. She's tachypneic. She had a lower BP, 90/60, and her respiratory had also fallen. But abdominal examination was soft, and the uterus corresponded to 18 weeks. So now, what would you say?
Madam, we should continue the broad spectrum IV antibiotics till she for 24 to 48 hours, or till she is febrile. And we should escalate the antibiotics if the culture and sensitivity report is according to the culture and sensitivity report. Or we, if the patient is febrile after 24 or 48 hours, we should reduce the antibiotic dose also. And also we should watch for the warning signs of sepsis, like we already said, the tachycardia, hypotension, all.
So
And also
tachycardia, pulse rate, respiratory
pulse rate, yeah, pulse rate, respiratory rate, the cognition of the patient, and the temperature, and whether it is hypothermia or a means fever, it is very suggestive. There is high chance for that sepsis in hypothermia also.
Yeah.
And also we should monitor the urine output. We should monitor all the system as well. And we should look for the uterine whether the uterus is atonic or not. And we should check the lochia also, the amount, the color, and the order of the lochia. And we should prophylactically, we should give uterotonics also. And we should have a fluid management protocol.
Okay, so the post-operative
Overhydrate or
orders.
underhydrate the patient. And also we should have a thromboprophylaxis along with the this, and we should give a this compressive bandage immediately after the cesarean section.
Okay, so prophylactic heparin should also be given. Now that she has sepsis, Dr. Lakshmi, could you tell us what exactly is sepsis and what is septic shock? Is it different from sepsis?
Yes, ma'am. Sepsis is basically a life-threatening condition where an infection will result in an organ dysfunction. And the organ dysfunction itself is described in terms of sequential organ failure assessment score. A SOFA score, when it has a fall of at least 2 points, we generally say organ dysfunction is there. When both these points are there together, it's called sepsis. For it to become septic shock, along with sepsis, the patient will also have superimposed persistent hypotension, that is a mean arterial pressure of less than 65 millimeters of mercury, despite giving vasopressors, and a persistently elevated serum lactate level of more than 2, despite adequate IV fluid hydration as well. So septic shock is a condition which has got significantly higher mortality than just pure sepsis. The mortality rate is said to be around 40%, and it requires early identification as well as aggressive treatment.
Okay, so what is the, I mean, all healthcare workers should be aware of the signs and symptoms of maternal sepsis, right?
Yes, ma'am.
And
So
yeah,
if any pregnant woman is presenting to us, she's looking extremely unwell, or if any of the early warning systems are triggered, then we should look for the red flag signs as well as the amber flag. If we have to see if they have any red flag signs, if there's any tachycardia, if there's any fall in SpO2, or any change in the urine output, a number of features are there. If anything is there, we should aggressively start treating it earlier. So here we have the modified early obstetric warning chart. That is a modified version of the early warning system, where using certain parameters, we can identify patients who are undergoing deterioration. So we can identify the patients who will require escalation of care.
yeah, that's very important because symptoms and signs of sepsis may be less distinctive in a pregnant woman when compared to a non-pregnant woman. So unless you're on the lookout for it, you might miss patients and they may deteriorate very rapidly. So, okay. So, Dr. Ramya, could you elaborate on the type of shock which we see in sepsis, and how does that affect the initial management? Is it different from the case we discussed before?
Yeah, because this is sepsis, it will cause distributive shock. So multiple organs are getting involved because of the sepsis. See, basically, when we tell sepsis, should understand there is SIRS is satisfied, SIRS criteria, where they've already told about temperature and the respiratory rate. It might be a little difficult because of the physiological changes in pregnancy. Sometimes you cannot apply this in a pregnant patient, and you will miss these cases. But SIRS can occur not only in infection in other condition also. But having said that, once the patient has been diagnosed with sepsis and septic shock, what will be the initial management is already it has been told. You are looking at the lactate levels, right? So if the lactate levels are very high, you have hyperlactatemia or lactic acidosis, the management
Next
is
slide, ma'am. Next
fluid,
slide, ma'am.
fluids and only fluids will be the main management here. And the role of vasopressors will come, as I've already told. If the BP is very, very low and you have to maintain organ perfusion, you have to start vasopressors. And noradrenaline is the norad, I've already told, it will be the first choice for no matter what shock you see, you should know noradrenaline well. That is one thing. And then already they've spoken about broad spectrum antibiotics. If you handle the sepsis well, I think everything will get corrected.
What type of fluid do we start with?
Uh,
Crystalloid, colloids?
No, you should start crystalloids. There was a controversy whether I have to start ringer lactate or normal saline that was going on so many times. And the surviving sepsis trial has told that you have to start balanced crystalloids. Like ringer lactate will be the better option here compared to normal saline because of hypercholeremic metabolic acidosis, which comes with a lot of saline. So ringer
Madam,
lactate.
madam, just may I just interrupt for a second, ma'am? Has Dr. Pradnya Supe joined? Our guest of honor, has she joined? Dr. Pradnya? Dr. Pradnya, have you joined?
Dr. Pradnya?
Yes, I have joined.
Yeah, good evening, madam. Good evening, madam. Ma'am, just
Yeah,
for
good
30 seconds.
evening,
Thank you, madam.
Dr.
Thank you, madam, please.
Yes, I have great joy in introducing our guest of honor, Dr. Pradnya ma'am, and actually she's she's our distinguished guest of honor, and she's the assistant editor of the Foxy journal Jogi, and she's a renowned laparoscopic surgeon, and she was formerly working in a medical college. And I extend my hearty welcome to you on behalf of the Kerala Federation of Obstetrics and Gynecology. We are extremely honored by your presence, ma'am. Welcome, ma'am, to our webinar.
Yeah, thank you so much, ma'am. I would really like to thank the Kerala OBGYN Society and Dr. Subhash and the President, Dr. Suchitra, for really inviting me as a guest of honor. I'm so sorry I couldn't join earlier, but really so nice to be a part of such an academically oriented webinar. And I think we should really continue with the proceedings. So thank you so much for really calling me as the guest of honor.
Thank you, ma'am. Thank you, ma'am. So we shall continue with the webinar.
Thank you, ma'am. Thank you very much. And sorry for the interruption. I'm sorry for the interruption. Thank you, Pradnya, ma'am. Thank you.
It's okay, sir. Okay, sir.
Thank you. Dr. Ramya, you were saying, according to the new guideline, ringer lactate should be given. The only problem is that ringer lactate will contain lactate and potassium, right? So unless we know the lab results, we may be actually causing problems by infusing ringer lactate in the as a first line. So better to go with the balanced solution, right? Plasma light kind of things.
Yeah, that is there, ma'am. But for people who don't have plasma light and such things, see, ringer lactate is lactate. It's not lactic acid. No? That's one thing which we should get out of our mind. But if you want to start normal saline also, it is well and good, because some people do give normal saline only.
Definitely no HES or albumin as the first line fluid management.
No
That's the
colloids.
most important thing. No colloids. No colloids. Okay. Dr. Sophia, could you elaborate on the investigations of this patient or for that
day of surgery, her
No,
investigation.
just tell us the changes. I mean, the investigations that you're going to send for a patient with suspected sepsis.
Yeah, we will definitely send for the complete blood picture. That is, this total count will be, it is elevated 43,000, and it comes gradually, it is coming down 32 in this in the evening, and the second and third day it is coming down, and like that. And her liver function test, the total bilirubin, and it is gradually increased, but it is on going like it is decreasing in the second and third days. And there is the coagulation profile, PT and INR is on the high. It is in the first half, it is 15 and it is escalated to 17. And the INR is
INR
1.4.
is increasing.
And
Okay.
it is gradually it came down. And
So these are the
there is the CRP is also increased in the initial hours. It is 101 and it is decreasing in the coming hours. That is the patient is improving. And the
Okay, so
serum lactate level, as the Ramya madam already said, it is the main thing that leads to the tissue it indicates the tissue perfusion, and the lactate level is very high. It is 21. If it is more than 2, it is the tissue is hypoxic. And the procalcitonin, it is the marker of the this thing back infection. It is also very high, and the D dimer also increasing. It is a little difficulty in pregnancy to assess the D dimer, but also still it is high.
okay,
And
so these are
the
the
fever profile also, that is negative. We did the viral markers and it is came as negative.
okay, so these are the set of investigations which needs to be done, which needs to be repeated. Okay.
Can't hear you, Bindu. Can't hear you.
Oh God. Now?
Yeah, better.
Now? Yeah. So these are the investigations which needs to be repeated, maybe 6th hourly, 8th hourly, depending upon how bad it is. And procalcitonin is basically for de-escalation of antibiotics. It does not correlate with the severity of infection. That's the most important thing. Once you do it and then you repeat it to de-escalate the antibiotics, and it just correlates with the bacterial infection, not viral infection. Am I right, Ramya?
Yes, madam. But when you use procalcitonin, as you said, it's only in gram-negative sepsis, it will give a better indicator. If you have a gram-positive anaerobic or fungal or viral, it will not be very high, and most of us will not have access to these tests, right? So what they're telling is, you look at the clinical scenario of the patient, and don't tell because procalcitonin is negative, it's not sepsis, it's nothing like that. But you look at the scenario in your patient, if it is gram-negative, it would have been high, and depending on your treatment, not only procalcitonin, even the clinical features, both together should it should improve.
Clinical features?
Then only
Both
you
clinical and biochemically. Clinical
Yes.
features, clinically improving, and biochemical improvement. These are the two things you look for before you, de-escalate the antibiotics. So sepsis bundles, just 2 words, Dr. Sharon. We are running short of time.
We're
I
running
think the
short of
same.
time. Yeah. So just
Yeah.
quickly, everyone.
We do use the sepsis bundle. So once we have a suspicion of a sepsis, we have to go for the initiation of the sepsis bundle. It includes one thing is you have to take the blood for culture. You have to take as the lactate level. If it is more than 8 sepsis and it is more than 4 millimeters, that would indicate hypoperfusion, that is septic shock. The next thing we take for investigation is the blood culture report, and we don't wait for the culture to come. We start her on the IV fluids, like as ma'am told, start her on balanced crystalloids. That is the rate of 30 ml per kg. We can start IV bolus, and then the further IV fluid can be. And then we have got the, without waiting for the culture report, we will start her on the broad spectrum antibiotics. Then if suppose her, in spite of the fluid resuscitation, if in spite of all the correction, if still her mean arterial pressure is less than 65, we will start her on vasopressor therapy, and we might even need to monitor her central venous pressure.
Okay, Ramya, just the basics of ABG in this scenario. Just tell us the basics. We have this patient's ABG. Next slide, ma'am. Yeah.
Okay. So first, what you do in any patient when you've taken an ABG is just look at the pH. You know the normal value is 7.35 to 4.5. Now this is less. So this is indicating acidemia. That means acid is there in the body. Now you want to know whether there is a metabolic cause for the acidemia or the respiratory cause. Look at the PCO2, it is normal, right? 40. So 35 to 45. So there is a respiratory part is removed. Next, look at the bicarb. It's 16. We need an average of 24 or between 22 to 26. It is low. So basically, what do we have? We have a metabolic acidosis. PO2 is less, that is indicating hypoxemia, which is understood for this case. And now once you get metabolic acidosis, you have to look at anionic gap. When you look at anion gap, you see it is elevated, it's to be 23. So 12 plus or minus 4 is the value. So when it's high, you have a high anionic gap metabolic acidosis. That means some acid is added to this patient's body. And what is that acid? Here it is lactate is high. It's more than 2. So that is lactic acid. So why this lactic acid is added is already told. Tissue perfusion is poor, hypoxia is there, anaerobic metabolism is going on. So the lactic acid is increasing. And that is the reason for this high lactate. And anything else, if you're looking at, it is written standard base excess. We know no base excess is going to tell about the metabolic part of the acid base imbalance, only the metabolic aspect. The negative value is telling it is more acidotic, positive value is telling it's more alkalosis. So when you have there is a base excess, you have a standard base excess. A standard base excess is going to definitely tell you that yes, it is there. It's like a standardized test compared to base excess. Base excess will just look at the buffering capacity of only the blood, whereas standard base excess takes the buffering capacity of entire ECF fluid. So it's a better indicator of your if it's negative, it's definitely there is metabolic acidosis. So this is some metabolic acidosis, high anionic gap. Yes, madam.
By the time, I hope you guys will step in, so we don't have to bother much about the ABG results, because this is always a confusion for us. Now, just a few words on antibiotic stewardship. I mean, it's very important because it's antimicrobial resistance it's a global concern. We're going to have more of antibiotic resistant related deaths it's going to increase by around 10 million in 2050. So just a few words, 2-3 words.
Madam.
Yeah, Dr. Sophia?
Yeah.
Dr. Ramya, whoever.
We should use a narrowest spectrum. Use the narrowest effective spectrum. It seems if we are having both anaerobe, gram negative and gram positive infection in this patient, so we should we suspect this in this patient. So we should start with the ampicillin with the gentamicin and metronidazole for this patient. And we should de-escalate the antibiotic once the cultures is when the cultures came, and we will return to oral antibiotics if the patient is improving. We should de-escalate into the oral antibiotics if she is improving. And the duration, as we said, the duration, if the patient is febrile within 24 to 48 hours, we should de-escalate the IV antibiotics and avoid unnecessary prolongation of antibiotics. And we should document the indication, duration, and the day of antibiotic in the case sheet itself. And we should reassess the patient every day, so that whether she is improving or whether the things are going bad.
So I think Sophia was talking about antibiotic stewardship. So initially we need to hit hard. So I think
next
Ideal
slide, ma'am.
antibiotics, because when we want to do 3 coverages and you don't want the IV lines to be bulging and giving trouble, because already the IVs will be very poor. So you can try giving them piperacillin tazobactam, which will give all 3 coverages, or you can try a meropenem, that will be better. And as Dr. Sophia told, based on your culture, then you can decide what to do. But most of the time, these 2 drugs are going to work. And another point I want to add is, if you're having drains and such things, you have to be careful whether fungal sepsis can set in. You have to be alert if patient is deteriorating. That's one thing. Otherwise, most of the time, these patients do well with what I told, peptas, and just look for MRSA if there is hospitalized and many tubes and multiple hospitals have gone and they're immunocompromised. Even MRSA, you have to think whether this patient fits into that and give MRSA coverage, maybe vancomycin or teicoplanin and whatever it is, based on that coverage. So ideally, if you don't know anything else, just start piperacillin tazobactam, or you can give meropenem 1 gram IV TDS for all patients and then decide your culture. And regarding one more, sorry, ma'am, regarding the fluid resuscitation, there is no specific thing that you have to give 30 ml per kg within thing. It depends on the patient's clinical status. You can go up or down. This was a recommendation done earlier. Now they have come down to suggestion. They said you decide on yourself. Looking at your patient, you decide how much amount you have to give. You can go up and down. You can escalate and de-escalate based on the status. That's it.
Yeah, the next slide. This is the most important thing that I would have liked to highlight. The right antibiotic for the right patient at the right. This is antibiotic stewardship at the right time with the right dose, right route, causing least harm to the patient and future patients. Your first dose should be adequate, and you should know what you're giving. Whether it's a time dependent, and you give Piptas BD 4.5 gram BD, it is not going to work. It's a time dependent antibiotic. So that way you should.
The voice
know.
has gone down again, Bindu.
I don't know what's happening, ma'am.
No, it's okay.
Okay. Yeah. I think we'll close. So.
Okay.
Yeah, ma'am. I think that we've already
We'll go
spoken
ahead
about
with
the
the next.
importance. Yeah. Should we continue, ma'am? I mean, like it's
I
9:30.
think, yeah, it's already more than half an hour. Dr. Tangu, I think we have one more session.
Ma'am, it would be nice if you can rush through the points, because
Okay,
these
right.
are points
Yeah.
which we cannot omit.
Yeah. So during ICU, if the patient is on prolonged care, Dr. Ramya, just tell us very quickly what all we should look out for.
You should be careful with critical patients. It's hypercatabolic states. You should be sure that the nutrition is taken care of. Secondly, ensure that the patient doesn't have bed sores. Be careful with that. DVT compression stockings you have to do. You should give more chances of muscle wasting, stiffness. So you should do early neuro rehabilitation. And respiratory care will come when once if the patient is off ventilator.
Yeah.
Otherwise, in between you can't do much. And mention, and as has already been told, that you should maintain perfect asepsis, ensure there is no added infection or hospital acquired infection. That's it.
Thank you. So after that, we just go quickly to the next patient. Now, she's a 35-year-old second gravida who came with fatigue, vomiting, and yellowish discoloration. So that's jaundice complicating pregnancy. With a bilirubin of 7 grams, enzymes high, but just 98-90, and platelets are low. So here now, what is the differential diagnosis that you want to make? How will you proceed, Dr. Sridevi? Just quickly tell us what are the 2 or 3 things that you will think of and how you will proceed.
She requires admission in the high dependency units. She needs close consultation with gastro or hepato consultation requires. The main differential diagnoses are HELP or hemolytic uremic syndrome or hepatitis, along with acute fatty liver of pregnancy. That is the most common, the indication we see in the diagnosis we see in this patient. The investigations, whatever I have mentioned, we have to put for viral markers also. Rapid viral marker results will also help in the diagnosis. And in the management also, the coagulopathy and hypoglycemia should be corrected aggressively before taking for termination in this patient emergency cesarean section. And blood products should be kept ready and should be transfused at the earliest.
Yeah. So basically, viral hepatitis is what we need to know. If the enzymes are very high and she is having an infection, that you can also get to know from the clustering history or the history of fever that other patients in the family have. In these cases, maybe you may not go in for an immediate termination. Most other cases, AFLP, HELP, if there's preeclampsia, you would like to go in for an immediate termination. And as said earlier, vaginal delivery would be better, but considering that these patients are remote from term and we don't have that much time, we may need to go in for a cesarean section. Now, in the presence of coagulopathy, whilst you're doing a cesarean section, as we've already said earlier, we need to, the senior most personnel will have to do it. Dr. Sharon, can you just touch upon the quick points that you will take care? Coagulopathy, jaundice complicating, and you're going in for a cesarean section.
Yes, ma'am. Here, we are planning for a cesarean section. The senior obstetrician and the senior anesthesiologist be involved, and also the coagulopathy side by side should be corrected. And next, by the CS, depending upon whether the or the general anesthesia would depend upon the coagulation profile of the patient. And we go for the antibiotics already been started, and then we go for the midline vertical incision to. Then all the hemostasis should be attained. Then while closing also, we have to the peritoneal drain and also the subfacial drain.
Yeah, so midline vertical incision is really helpful because it reduces the amount of intraoperative hemorrhage that you have. And suppose you have a postoperative, like you've done all this, but your drain output is still coming quite high, 500 ml over 4 hours. What would you do?
Then we have to coagulation.
Again, yeah, think of the coagulation profile. If the coagulopathy is not corrected, that is what you need to do first. Then only if the coagulopathy is corrected and still the drain output is high, then you'll think of some intraperitoneal bleeding and whether you need to go in. As we said earlier, decision for relaparotomy has to be very carefully thought out, right? Now here, I just want to touch on hepatic and renal support. So Dr. Ramya, she's going in because she's got this hepatic problem, her ammonia levels are rising. She develops flaps. What supportive measures?
So we know ammonia is neurotoxic. Only two things happen. One is you ensure there is no constipation, so you give lactulose, or you should do an enema, ensure 3 or 4 bowel movements are there, and rifaximin works well. It's an antibiotic which will cut down the ammonia producing flora in the gut. That is two things. And other supportive measures, it's already been stressed that hypoglycemia is very dangerous, so you have to monitor and give her dextrose and dextrose containing infusion, and the rest of the coagulation things has been spoken about. And regarding kidney injury, there is, you can have pre-renal or renal oliguric renal thing. You have to give fluids and see the output, and based on that you can see whether the patient is making urine or it's, there is input but there is no output and developing pulmonary edema. Then you have to maybe give diuretics and see. You can give a diuretic challenge and see whether the urine output is increasing. Secondly, potassium is going to go high in this patients. So based on that, if potassium is very high and ECG changes are there, we are going to give measures to control the potassium, calcium gluconate, nebulizing, glucose, insulin. And if patient develops metabolic acidosis, then there might be indications for starting renal replacement, especially if this hyperkalemias, you cannot control with the regular measures, as you cannot control pulmonary edema with your diuretics, and the worsening clinical status of the patient, they might land up with hemodialysis. And depending on the condition, frequency, sometimes they land up with the chronic kidney disease. So that is the thing.
So make a presumptive diagnosis, and you need definitely, as we said, multidisciplinary care. Just a last case, a couple of slides, Bindu.
Yeah,
Because this is
audible,
something
ma'am?
that we really, audible now.
Audible? Yeah. So
Yeah.
she's a 22-year-old priming gravida, spontaneous labor at 39 weeks, rupture of membranes. She was given cefazolin. In a few minutes, she developed dyspnea, wheeze, tachycardia, and hypertension with a slowing of the fetal heart rate and collapsed. So the possible causes of maternal collapse are the 4H and the 4Ts. But then, next scenario, ma'am. Because she had a bradycardia, the fetal bradycardia, pulse was feeble, BP not recordable, we suspected an AFE. She was rushed to the theater, but by that time she developed flushing of the skin, erythematous lesions on face and rest of the body, and dark colored blood on incision. So now the diagnosis is very clear. Now we'll straight away go to Dr. Ramya. Please tell us, how will you manage this anaphylactic shock?
Okay, the anaphylactic shock, first thing you have to remove what caused the anaphylaxis. So you should stop the infusion. That's one thing you shouldn't forget. This patient will go arrest anytime. You need a lot of help. If it's possible, raise the foot end of the patient, because this vasodilatory shock is one of the most dangerous one. It will empty your ventricle. There'll not be any blood in that. So if it is possible, raise the foot end. Look at whether the patient is having stridor or angioedema, and that becomes a little difficult. Main treatment is putting two large bore IV cannulas, flushing, and lot of saline, 2 to 3 liters, calling for help, and start give them adrenaline. It is 1 in 1,000. You take it as 1 milligram per ml, take 0.5 ml of it and inject it into the lateral aspect of the thigh, specifically that side, because it has got good blood flow and it will reach the systemic circulation very fast. And you'll have 5 more minutes before the second dose. Meanwhile, you can give her steroids, methylprednisolone 125 or a hydrocortisone, and maybe an H1 or a H2 blocker IV. In 5 minutes, if the patient doesn't respond, you can try one more dose of 0.5. Meanwhile, don't forget to look at the oxygen. You can give a high flow, either you can do NRBM, or maybe if sometimes you'll have a stridor and such things. You need people who are capable of handling the air with anesthetist. Maybe you'll have to do a tracheostomy. It depends on that. So airway part has to be handled, and usually 98% of the patient respond to 1 or 2 doses of adrenaline IM. But in case your the patient is not responding, still in hypotension, you should keep something in mind that this patient might be going for a refractory anaphylaxis. Meanwhile, you can give the third dose, and still there's no response. You can start adrenaline infusion. There are protocols everywhere you can follow, and in spite of that, still it is there. You may have to give other vasopressors. Most of the patient, by 98% of the patient, will respond to your second dose. And don't send the patient away. Keep it in ICU, monitor for 72 hours, because something called a biphasic reaction comes. even if you have removed the cause for the anaphylaxis, some patients go on to develop one more anaphylaxis after 72 hours. So that biphasic reaction is something that we should not forget. Yes, ma'am.
Good. So actually there is no absolute contraindication to epinephrine in this setting. So that's the most important thing that we need to realize, because there's no time for help come in. So you have to act immediately. And as I
And
said,
it's
no
the same
absolute
dose for the pregnant woman. Same dose for the
Yeah.
pregnant
pregnant
woman.
woman.
Okay.
And in pregnancy, you can keep the patient in the left lateral position with the feet up to avoid
Fetal.
that empty ventricle syndrome. And you have to be on the lookout for fetal bradycardia and the need for emergency section.
So
That
whenever
always
there's
is
this
there.
hypertension, you're going to get a fetal heart rate slowing, and so that part has to be also managed simultaneously. Right.
So at the end, it's do what you can with all you have wherever you are to save the patient.
And one good rule of thumb is that what is good for the mother is usually good for the fetus, because we've got two patients and we can't ignore the other one, right? So I think we'll stop at that. I thank all the panelists. I thank Dr. Bindu for helping me out and co-chairing the session with me.
Thank you,
And
ma'am.
for all the panelists for their very active involvement, and Dr. Tangu for her overall supervision.
Yeah. Thank you. Thank you all.
Our experts are there, Dr. Hariprasad and Dr. Omana ma'am. Ma'am, sir, would you like to say something? Give us some expert comments.
Yeah. Yes, yes. First of all, let me congratulate the two new chairpersons, Dr. Tanku and Dr. Rani. Anyway, I think your combined both together is done very well, because every day we are having one or other webinars. And the topics you have selected for today is very useful topics, and especially for the practicing obstetricians. And the discussion was so practical. I really appreciate. I know Dr. Sajjala and Dr. Biddu are very well-known teachers, and today was proved it. Because and also Dr. Mumtaz, you have done taken all the practical points, and even if it is very late, I think it is very useful, very useful to us. So we hope more and more discussions like this from you. I call upon Dr. Hari Prasad for his comments. Thank you very much. Thank you very much, and good night.
Good evening. Gives me very pleasure to take a part in this session. It's a very good session conducted by Dr. Sajila and Dr. Bindu. All the participants presented very nicely. Acute maternal collapse, particularly in the context of labor and delivery, remains one of the most feared emergencies in the obstetrics, as demonstrated by the present case scenarios. Conditions like amniotic fluid embolism, anaphylaxis, sepsis, and acute liver conditions are all potential culprits, each with a subtle variation but overlapping features that demands swift, structured, and multidisciplinary responses. So what I feel is for the last many years in attending the CRMDs, most maternal deaths are preventable. The cornerstone of reducing maternal mortality is the preparedness at every level. Unfortunately, many deliveries occur in the setting lacking the critical care infrastructure and emergency response systems. Hence, the training in the early recognition and rapid response and team coordination, core drills, mock drills, just like the security guards doing 2 days back. These are very important. Every delivery points, irrespective of the tire, should be equipped with crash cart, including airways, resuscitation bags, and crash cesarean kit. Standardized charts like a Muse to detect early deterioration in case of sepsis is essential in the post-operative care. So I feel the obstetrician should not stop only by delivering the babies, but it is our duty to treat, not just to treat, but to lead. Leadership means advocating for the preparedness insisting on mock drills, demanding equipments and mentoring our teams, all these things. So PPMD workshops, they give a lot of training. It should be continued in every districts. Thank you.
Thank you.
New doctors are coming. Actually, new doctors are coming. So this has to be repeated and we have to train them to do it on the spot. Thank you. Thank you.
Thank you, sir and madam, for your valuable points. Dr. Rani Lakshmi, please take over for the fetal session.
Okay, it's very late actually, so we'll be running through the last session. Also, there's a slight change in topic. Dr. Archana, our next speaker, will be talking on soft markers for 15 minutes. And I'm happy to introduce our chairperson, Dr. Shaheen. She's a young budding fetomedicine consultant at NCare Cannanore and also a Dream Hospital, Dreamflower Hospital, Kasargod, and Dr. Nebisa from Kamath Hospital, Kasargod. Dr. Shaheen, can you please introduce Dr. Archana? Dr. Shaheen? Okay, Dr. Archana, are you there?
Yes, ma'am.
Okay, I think you can start right away with, sorry for keeping you waiting for so long. And okay, you can continue with soft markers.
Thank you, KFOG team, for giving me an opportunity. Actually, it's pretty late for everyone, so I'll try to go as quickly as possible with this topic. Today I'll be speaking about soft markers, mainly second trimester soft markers. So we all will be used to soft markers during our routine scans. So soft markers are basic certain structural findings which we see during our routine scan, which are mostly a transient finding, and most of the times these are normal variants. So whenever we find a soft marker, there are many soft markers. Some of these most common ones are the echogenic foci, the choroid plexuses, renal pelvic dilatation, which are the minor soft markers, which most of the times are very insignificant findings. Whereas a little more, that's important ones, that's the major soft markers includes the absent nasal bone or hypoplastic nasal bone, increased NFT, as well as mild ventriculomegaly. Then other common soft markers, what we commonly see is aberrant right subclavian, ectogen bowel, and so on. So I'll be dealing with each of these. So whenever we see a soft marker, the first question is whether we see a single soft marker or multiple soft markers. That will change our management. So then the question comes to us is, does it matter or not? So finally, the main question which comes to us is, do we need further testing to rule out trisomies or any other aneuploidy or not? And the question which the patient will be having is, will it cause any problems to their fetus during the postnatal life? So these are the questions which has to be answered when we see a soft marker. So coming to a case 1, which is a G2P1L1, she's a 24-year-old lady. She comes with a risk of trisomy 21, first trimester screening risk of trisomy 21, 1:696. Most of the times, this is actually missed because it will be coming as low risk in our reports. This is actually an intermediate risk. So in such cases, we can either opt for an NIPT or we have to do a genetic sonogram to see for any other markers are there or not. So she comes for a routine anomaly scan, and once we do the anomaly scan shows no major structural anomaly except for 2 soft markers. So these are the soft markers. One is echogenic foci and the other one is aberrant right subclavian artery. So these both in isolation can be a normal variant. Aberrant right subclavian has a higher likelihood ratio, but still whenever we have an echogenic foci, most of the cases we have an echogenic foci, which are just calcific spots in the papillary muscles of the heart. So most of the Asian population, almost around 30% of the Asian babies actually have this echogenic foci. So these we have to tell the parents that they need not panic. But the only thing they need to do is we have to search for other soft markers. Second finding which we got in this patient was an aberrant right subclavian artery. So it's an aberrant cause of origin in the right subclavian, which is also a completely normal variant, but occasionally this can be seen in Down syndrome babies as well as in DiGeorge babies. So whenever we see two soft markers, what we do? We calculate the risk. That is, when we have a combined test risk, we can actually recalculate the risk by using these LR ratios and recalculate the risk to find out a new risk. So when we add the echogenic foci to this becomes 733. And when we add two soft markers to it, we can see that the risk is markedly increased. So when it comes under high risk, if we go only by the combined test report, we might miss this. So when we have to recalculate the risk when we find the soft markers. So once the calculated risk is very high, we have actually done an amniocentesis and that has come a positive for trisomy 21. But if at all it comes negative for any of the aneuploidy, this is absolutely considered as normal variant and the patient can be completely reassured. Coming to another case, which is actually a 32-year-old, she comes a G2P1L1. She comes for routine anomaly scan. Screening test was not done. When the screening test is not done, we actually don't have a prior risk to calculate if they have any soft markers. So in such cases, we'll be using the age risk as a prior risk. So here, so we do a scan for her and we find an unossified nasal bone. So whenever we find an unossified nasal bone, we know that it is a major soft marker. So irrespective of whether the combined test is a low risk also, we have to offer them further testing. So so whenever we do it amniocentesis and we get for an unossified nasal bone, it's not always that we go for a trisomy 21. There can be other findings like sex chromosomes. Even deletions and duplications can occasionally be positive. But if at all, if all these things, so this is how we measure the nasal bone. So if the amniocentesis is normal in a hypoplastic or absent nasal bone patient, the patient has to be completely reassured that the baby is going to be normal unless other associated findings are there. And it is not a hard and fast rule that we just look at the nasal bone. There are many other, the facial profile also plays an important role. There is a flattened facial profile or frontal bossing. These are all subtle findings which can be missed, so that has to be carefully looked for when we are doing a genetic sonogram. Coming to another case, which is an echogenic bowel. So the patient is screen test negative. And during anomaly scan, if we see an echogenic bowel, this can be completely reassuring because it's a minor soft marker. In isolation, this can be a minor soft marker, which need not require any further testing unless there are associated soft markers. So the patient can be reassured, but we have to follow them up. One is we have to rule out any infection history is there. Along with that, there is any GI pathology is coming up later on in pregnancy. Also, we have to follow them up for. Coming to the case 4, which is actually a 39-year-old patient who comes to us with ventriculomegaly. So whenever we see a ventriculomegaly, the two things which has to become, it is a major marker for trisomy 21. So whenever we see a ventriculomegaly, we have to see the brain completely, do a neurosonogram, see for associated brain abnormalities are there. Most of the times at 20 weeks, this will be an isolated finding, but it cannot be considered as an isolated unless we have a follow-up of these patients, because many of them can have cortical abnormalities which can develop later on during pregnancy. So one thing which we have to rule out is Down syndrome, and the second one is infections. And since the ventriculomegaly is a major soft marker, we can directly go for testing. Along with that, we have to do an infection also to be ruled out. And if both are ruled out and it's only the mild variant, most of these babies actually do well unless there is a progression in the ventriculomegaly or new associated findings don't develop in these babies. The patients can be reassured that mild ventriculomegaly, that is about 10 to 12 mm dilatation, most of these babies, almost 90% of these babies have a normal neurological outcome. So this patient, CMA was suggested and along with TORCH PCR was done, and this was negative. And the patient was followed up. No other abnormalities came up later on, and the baby is actually fine. So mild ventriculomegaly is but a major marker for trisomy 21. So coming to the case 5, which is a case of renal pelvic dilatation. This is another one common finding which we always notice during our routine anomaly scans, where there will be mild renal pelvic dilatation. So these are very subtle findings and very minor markers, which does not increase the risk for trisomies, that does not cause a marked increase in the trisomy 21. So whenever these soft markers like an echogenic foci or minor renal pelvic dilatation is there, we can just follow up these patients unless there is a gross obstructive pathology which is there. So this isolated mild renal pelvic dilatation or echogenic foci is not an indication for further invasive testing unless there is any other indication for it. Then coming to the case 6, which is actually a 27-year-old primary gravida who comes with first trimester screening is negative. And she shows there is large choroid plexus cysts there. So for the patient, it will be scary to see cysts in the brain, but this is also a minor marker. Usually within a week or two, this will actually resolve. And this patient also had an increased NFT. So this choroid plexus cyst is a minor marker, but increased NFT is a significant finding. Whenever we see a nuchal fold is increased, we have to offer further testing because that is a major marker for trisomy. So increased nuchal fold thickness, the likelihood ratio is 3.8. That means there is a 3.8 times there is an increase in the risk for trisomy 21 for her. Choroid plexus cyst is a minor marker. So when there is increased nuchal fold thickness, that is when it is more than 6 millimeter, we offer further testing and also look for any associated findings are there. Choroid plexus cyst is a minor marker for usually trisomy 18 as well as 21. But in isolation, this is absolutely a normal finding and usually it resolves within a week or two. And no further testing is required in an choroid plexus cyst. Final soft marker, which I'll be talking about, is a single umbilical artery. This is a single umbilical artery is also a very common finding, and most of the times this is a minor soft marker, which is absolutely not going to create a problem, except that the baby can present with IUGR later on in pregnancy. But we have to do a thorough genetic sonogram to rule out any other soft markers for aneuploidy is there. Along with GI as well as cardiac abnormalities has to be ruled out before we tell them that the baby is absolutely or is going to be normal. So isolated presence of single umbilical artery is not an indication for testing. Take-home points are we always have to do a first trimester scan along with screening because that is the first time where we can identify major anomalies, and early anatomical survey along with screening should be offered for all these patients during NT scan. Genetic sonogram at 20 weeks, we have to see for soft markers, congenital abnormalities, and any subtle changes are there which are pointing towards aneuploidy. If there are multiple soft markers, always recalculate the risk to identify whether there is any need for further testing or not. And always discuss the significance of soft markers to the couple because the patients will be extremely worried when you see that there is a spot in the heart or a cyst in the brain. So these are minor markers and the baby is completely going to be normal. We have to reassure them. And finally, whenever we find there are multiple soft markers or major soft markers, always offer them invasive testing because they need to know about what can be done and how healthy their baby is. Thank you.
Thank you, Archana. That's for that short and precise presentation, but I think it's very important because markers all are the important thing is for very minor markers like EICF and choroid plexus cyst, people are actually getting panicked. I think that should be avoided. For a panicking for an EICF and referring for a echo for an EICF and CPSS, that I think that's very important for the practicing of obstetricians. And I think Dr. Shaheen can add on something. Dr. Shaheen?
Thank you, ma'am, for this opportunity. Thank you, Dr. Archana, for such an insightful session on soft markers. Yeah, we really see these soft markers, second trimester ultrasonographic markers in our daily practice. Certain markers are really considered as soft, like echogenic intracardiac focus and choroid plexus cyst. When isolated, we need not really panic and jump into like invasive testing or termination. While certain markers like hypoplastic nasal bone or unossified nasal bone, increased nuchal fold thickness, ventriculomegaly, this cannot be considered as soft though, but yeah, these sonographic markers requires further testing to prognosticate the pregnancy, so that this gives more reassurance to prospective parents and obstetricians as well. I thank Dr. Nabisa ma'am for for sharing this session with me. Thank you, Lakshmi ma'am, for this opportunity.
Dr. Nabisa, do you want to add something?
And thanks, Dr. Lakshmi, for giving this opportunity to become a part of this webinar. It's a very nice topic and day-to-day practice. Every time we are seeing the scan, even we are also getting panicked, and we are patients also getting panicked. Always I discuss such cases with Dr. Shaheen. She is giving a good backup for me. Thank you. It was a good, crisp and clear topic. And Dr. Archana, it was very informative talk.
Thank you so
Thank
much,
you for
madam. Thank you,
this
Lakshmi ma'am, and
very informative.
for the opportunity.
Let me see if there are any questions. I think it's very late at night. So I think there are no more questions. Thank you, Archana, once again.
Thank you so much, madam. Thank you so much for the opportunity.
Thank you. So last, let me go on to the vote of thanks. Thank you, President Sujit. One thing I forgot to tell, Archana is the daughter of our President, KFOG President, Dr. Sujitra Sudhir, Madam. Madam, you're sitting there. She has gone, Archana?
I know she's there.
Okay. Thank you, KFOG, President Dr. Sujitra Sudhir ma'am, and Secretary Subhash Malya sir for such a great effort like KFOG at webinar. And thank you, the past President Kunjumoideen sir, for such a great vision. Fetal medicine also becoming part of a KFOG, and I think more and more fetal medicine should come into the focus for the practicing obstetricians. Very important nowadays, and it's his vision only that the fetal medicine has also become a part. Thank you, Subhash Kunjumoideen sir and Sujitra madam, and thank you, our guest of honor. She had come late, Prithvi madam. Then Tangu madam, thank you for your great effort for organizing this webinar, and thank you all chairpersons, delegates and other faculties for attending this session. Thank you. Good night all.
Good night. Good night.
Good night.
Good night.
It was
Good
a
night,
real good
madam.
effort. Congratulations to both
Good
of
night. I
you.
think we.
And
Good night, madam.
thank
I think
you,
we should.
everybody.
Okay. Bye bye.
Tangu doctor really followed up everything. Each and every
Yeah.
day you were giving messages.
Okay.
Okay, Rani.
രണ്ട് പാനൽ വെക്കുന്ന ഒഴിവാക്കേണ്ടി വരും തോന്നുന്നു.
അതെ, ഒരു പാനൽ മതി. ഇതൊരു മെഗാ വെബിനാർ ആയി പോയി.
മെഗായായി. രണ്ട് പാനൽ വെക്കുന്ന ഒഴിവാക്കിയിട്ട് ഒരു ടോപ്പിക്, 3 ടോപ്പിക് ഒരു പാനലും ആക്കാം.
ഇനി തൊട്ട് അങ്ങനെ ആക്കണം.
അങ്ങനെ ആക്കാം. ശരി മാഡം, താങ്ക് യു. താങ്ക് യു മാഡം.
ഞാൻ അതിന്റെ ഇടയ്ക്ക് റിസപ്ഷന് പോയിട്ട് വന്നു.
ഓമനാൻറ്റി ടാറ്റ.
Good night. Good night.
Good night.
Good night, madam.
It's very nice to see you all today. മോളെ കണ്ട് ഭയങ്കര സന്തോഷം കേട്ടോ.
നമുക്ക് സന്തോഷാണ്.
Thank you, Sujitra ma'am. Thank you, Omina ma'am. Thank you, Rani.
Thank you, Tangu. Okay, bye.
ഇന്ന് ഇതും ഉണ്ടല്ലോ നമ്മുടെ ട്രോഫോബ്ലാസ്റ്റിക് ട്യൂമേഴ്സ്.
അതെ അതെ അതെ, ഒരുപാട് എണ്ണം. എല്ലാരും പഠിച്ചു നല്ലോണം.
സാച്ചുറേറ്റഡ്.
Bye. Good night. Good night. Bye.
Bye.